All right, good morning, everyone. It is 8:05 a.m. on June 13th, 2025. I'm going to go ahead and call the full board to order. If we could have the roll call.
Yep. Dr. Zaffron,
Present.
Dr. Farmer, Mr. Kokonos, Mrs. Barnes.
Present.
That was Mr. Kokonos, I think. Dr. Bhatia, Mr. Crane, Dr. Deloche,
Present.
Mrs. Del Rosal, Dr. DeStefano,
Present.
Mrs. Herod,
I'm here.
Dr. Jones,
Here.
Dr. Martinez,
Here.
Mrs. Morgan,
Here.
Dr. Nadeau, Dr. Quinones,
Present.
Dr. Tibbles,
I'm here.
Mrs. Troncoso, Dr. Vanderwide, Dr. Green.
Present.
All right, let's see. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. All right, we have a quorum. Barely. Can proceed.
All right, thank you. All right, as always, we begin with our mission statement. Our mission is to protect and enhance the public's health, safety, and welfare by establishing and maintaining standards of excellence used in regulating the practice of medicine and ensuring quality health care for the citizens of Texas through licensure, discipline, and education. The first item on our agenda is the board member report. First thing I'd like to do is to welcome one of our new board members, Dr. Kelly Green. Dr. Green studied chemistry and French during her undergraduate years at Trinity University in San Antonio, went to medical school then returned to San Antonio for residency in ophthalmology. Currently serves as a clinical instructor at UT Health Science Center and faculty of the Department of Ophthalmology. She joined the Kirby Eye Center in Marble Falls, Texas in 2009, and is a member of several organizations. Enjoys running, which we did quite a bit of yesterday for a long day, swimming, and spending time with her family in the Texas Hill Country. Dr. Green, welcome on board. I think we kind of broke you in yesterday with a nice long day, which was a little unusual, but welcome on board.
Thank you.
As we talk about a new board member coming on board, we are also saying farewell to one of our other board members, Dr. Nyack. As we traditionally do, we have a resolution that we have in Dr. Nyack's honor that reads, whereas the members of the Texas State Board of Medical Examiners wish to express their appreciation to Satish Nyack, MD, for his dedicated service on this board from 2019 to 2025. And whereas he was keenly aware of his responsibilities as a board member representing the citizens of Texas, and whereas he gave unselfishly of his time and energy while serving on the board, and whereas his efforts toward resolution of issues were appreciated by all, and whereas he was a valuable and dedicated member of the board and contributed his time serving as a member, now be it resolved that the members of the Texas State Board of Medical Examiners join together to honor Satish Nyack, MD, for his service, and further, that a copy of this resolution be tendered to Dr. Nyack and that it forthwith be inscribed upon the permanent minutes of this board. So with that, a virtual clap for Dr. Nyack and his service to the board.
Dr. Zaffron, can I add something, please?
Yes, sir.
5 minutes ago, I just text Dr. Nyack and I said, good morning, Satish, wishing you and missing you, wishing you well and missing you. And he says, thanks, Manny, miss you all too. Can't believe how life can change from one day to another. I guess we have to go with God's plan and just keep doing our best. You all have a wonderful week and please convey my love and regards to all my friends on the board. God bless you all. So he's doing well.
Thank you, Manny. And we certainly wish him well also. All right, the next item is a presentation by K-Star. Mr. Carlton?
Yeah, I think we have Tracy Adams and maybe Dr. Steele here to give the presentation. Not in person, but I think virtually.
Yes, so just trying to get my camera and my mic on. And Dr. Steele, are you on?
I am. Can people hear me all right?
Yes, we can hear you and we can see you. Good
Okay.
morning and thank you for being here.
Good. Thank you very much. I'm going to start out and then Tracy's going to finish up. Good morning and thank you to the Texas Medical Board for letting us present updates on K-STAR medicine programs. It's hard to believe, but K-STAR is now about 18 years old. And it's been almost 5 years since we presented anything to the board. And really a lot has happened during that time, and we're excited to share the progress we've made with all y'all. Now, do we have a presentation up? That's all right. The objectives, we're going to be going over basically K-STAR medicine programs, a little bit on physician reentry. I'm going to introduce you to some of the work we've been doing on return to board eligibility pathways with several specialty organizations. And we're also going to touch a little bit on the alternative pathways to licensure and the role K-STAR may have for assessment and remediation. At the very end, we've got a couple of offers to make to the medical board, and we have got a few small asks to make of the medical board. Next slide, please. All right. One of the things that's new is we've got more staff now at K-STAR. Instead of it being just the Rob and Tracy show, as we called it, now we have a new medical director, Kia Parsi, who is the executive director of the Rural Community Health Institute at Texas A&M. We now have 4 assessment facilitators instead of 2, 3 report writers, and we have 1 fantastic program manager who is Tracy Adams, and you'll get to hear a little bit more from her. So that gives us increased capacity and flexibility, which we had been needing and wanting for a long time. And that's really allowing us to stretch out and do more work and to go into different directions, which I'll talk about in just a few minutes. Can I have the next slide? So we will be going through all these programs, and you can advance to the next slide also. And let's see. Sorry, we got a little out of sync here. Okay, so for K-STAR physician assessment, we've assessed physicians in almost all specialties, and they don't fit on one slide anymore. In fact, it's easier for us to tell you what we don't assess or have not been able to assess. And the one that really stands out is pathology. We don't get a lot of requests for pathology assessment or reentry training, but we do get them. And it's a more challenging assessment to design and to execute. And it's very difficult to find peer assessors who are willing to engage in this type of activity. I'll talk a little bit more about that at the end when we come down to the asks and offers slide that's at the end. When it comes to assessment, there's a couple of surprises. We've gotten some work done in the last 5 years that I didn't think we would ever be doing, really. We've done a handful of neonatology assessments. We're doing more and more anesthesiology assessments. We've done a handful, I think, of neurosurgery assessments, and most recently, cardiothoracic surgery. That's a big one to take on. And all of these included reentry training programs. So we were able to do the assessments and successfully get them trained and through the programs. And all of the people so far have successfully completed the programs. One thing that really stood out, though, is the amount of I couldn't believe how much anesthesiology we would end up doing. And it's actually a very enjoyable and gratifying experience to work or be a part of these. And we, two faculty at UTMB, where most of our training is done, two anesthesia faculty actually wrote an article about what we're doing. And the article was called, "Can an Anesthesiologist Return to Clinical Work After a Career Hiatus?" And that was written by Amir Abulish and Kenneth Moran. And and it was published in the ASA Monitor September 24th, and really highlighted the KSTAR/UTMB approach to evaluating and doing reentry training for anesthesiologists. So this has become a part of what we do, and we're happy to do it. Next slide. Okay, the next thing I'm going to be talking a little bit about is reentry training. It's no secret that we do reentry training. I think we have the only program in existence that I know of that does most of their training in residency programs that are ACGME approved and accredited. And usually reentry is done on physicians who've been out of practice for more than 2 to 5 years, depending on what state you're in. Type and length of training is usually determined or at least influenced by KSTAR assessment. Training sites reserve the right to decline physicians if they determine not to be good candidates for training. I wish we could accept everybody into the programs, but we simply don't always have the capacity to do that. We have a steady flow of trainees going through both UTMB and Driscoll Children's Hospital. And as always, we're seeking initial training capacity and options because we do know there are more doctors out there who would benefit from this service that we can provide. And let's see. And one of the things that we do with these programs, and this is kind of an offer up to the Texas Medical Board, is every physician who finishes the KSTAR UTMB training, assessment and training, when they're done with their training, they have to present a portfolio of basically everything they've done during that time. And it's really a very enlightening experience, and we'd like to, and uplifting too, I should say. And we'd like to offer to the UTMB, any representative of the UTMB can attend one of those meetings. They're only 30 minutes long, but they're really packed with a lot of good information, and you'll really understand very quickly how comprehensive the program is. Just as a side note, not to brag, I've been a content expert for the FSMB work group on physician reentry for 2 years from 2023 to 2025. And basically, we looked at updating the document that previously existed on physician reentry that the previous work group worked on. And I'm happy to say that it was approved by the FSMB at the most recent FSMB meeting. And I think you'll find, I don't know if you can basically find it on FSMB's website, and you can actually just Google it to work group on reentry FSMB 2025. But there are more. It proposes guidelines and identifies resources for reentry. And overall, this document I think is more specific, more granular, and I think overall more helpful when it comes to reentry. And so I think that's all I got on reentry for an update. Next slide, please. KSTAR Fitness for Duty evaluations. We've been doing this for 10 years, and it's a little different than doing KSTAR assessments, but it's very important. Fitness for duty evaluations are basically, physician health evaluations. We're looking at their physical health and their cognition and their physical abilities. And we've been doing this for over 10 years now. Entities that we serve are hospitals, clinics, PHP, anesthesia groups, and of course, TMB. And the modalities that we most frequently employ are physical examinations a neuropsychiatry evaluation, occupational therapy evaluations of the upper extremities for eye-hand coordination, cognitive screening, and or neuropsychological testing. We really have quite a cadre of these now, and we've learned some things that are kind of surprising and a little concerning. Of all the people that we have evaluated, really only 25 of them come out looking okay. 75% of them have at least a mild difficulty or concern. And there's a minority of them, about 10 to 15%, who really need to stop practicing medicine, at least for a while, or, forever. And the other thing that's concerning about it too that we're learning is that concerns about physician performance usually predate their referral to us by 6 to 18 months or longer. And that's concerning because that's a long time where patient safety most certainly could be at risk. And so I don't have the answer for this, but I wish there was a way to identify physicians a little earlier so that intervention could happen and the amount of time that people may be exposed to a patient safety risk can be minimized. That's kind of it's a little out of range for what I know and know how to do, but I certainly can see a problem when I see it. And so the other thing that we do, and this is a little more fun with Fitness for Duty, is sometimes we simply evaluate people to see if they're ready to go back to work after an accident, injury, or a stroke or something like that. And most of the time people do get to go back either with no restrictions, or there may be some minor restrictions in what they do to allow them to go back to practice. And that's pretty much the end, I believe, of what I was going to present. Tracy's going to follow up and now discuss a few of the more recent things we've been doing. So Tracy, I'm going to turn it over to you.
Great, thank you. Next slide. So our return to board eligibility programs are new. They started with the American Board of Family Medicine in 2021. We added emergency medicine in 2022, pediatrics in 2023, which has been our most popular. And then we're working with the ABPM&R board, and we'll get that done in 2025. We're in the contracting part. So these are programs that are for physicians who have timed out of board eligibility, not physicians who have lost their board eligibility. But it started with family medicine, and they realized that their requirement of 1 year of going back to residency just wasn't feasible for physicians, and they were looking for an alternative. So we partnered with them and developed a new program. Next slide. So each of these programs are very similar, but they differ a little bit depending on the board. So what we do is a baseline assessment, which is kind of a somewhat toned down of our competency assessment. It's not a pass or fail. There's no reason to believe that these physicians aren't doing well. It's all about education and helping them become better physicians and help giving them a study plan and some tools so that they can become board eligible and pass their board certification test. So we do the baseline assessment, and then they have 6 months of training and education. They have to be approved for the program by the specialty board, and their supervisor has to be approved by the specialty board. So then for 6 months, they meet with their supervisor once a week to review records. We have a pharmacology module, an ethics and professionalism module that we do. We send them lots of education on what I call the soft skills, test taking, stress management, goals. These are good physicians. They're beloved by their facilities. They just aren't able to pass this test. And as you know, being board certified was the gold standard, but now it's hard to even get a job if you're not board certified. So they also have to get between 90 and 150 CMEs. We give them Roche Review, which is a test bank and a great way for them to study, and we work with them for that full 6 months. We're still kind of in low numbers because the program hasn't been around that long, but we've had some that have gotten board certified and returned, well, they're all on practice, but been able to move on to better practices or feel better about their practices. Nobody has timed out of eligibility again because they have 3 to 7 years of board eligibility depending on the specialty board. So every time board certification exams go out, I'm busy Googling to see who has passed, and it's very rewarding when we get one of our physicians board certified. I think that's all I wanted to say about that. Next slide. Because this kind of leads me to the alternative pathways. So this is a big topic, as you know, everybody's kind of struggling with, talking about the state legislative bodies are getting involved, internal medical graduate, international medical graduates, and all the different things that are kind of coming up. And we just wanted to let you know that if you're thinking about alternative pathways, we'd like to be a part of that with you. We think the return to board eligibility model might be good, but we're willing to work with you on any model, talk with you about it. If there's a place for us to be there, we'd like to use our re-entry expertise and our assessment expertise and work with you on it. Next slide. So I wanted to introduce you to a couple things you might not know about the Coalition for Physician Enhancement. That is a board, a group that is made up of the assessment programs in the United States as well as our Canadian counterparts. Dr. Steele and I are both members on the board. We have an annual conference every year. We have webinars. We do a lot of networking, and we are having our annual conference this year in October at the American Board of Medical Specialties office, and it's going to be on the vital role of assessments for alternative pathways to physician licensure. If anybody's going to be in Chicago or wants to come to Chicago and join us in October, we'd be glad to have you. Next slide. Along that line, our next webinar is coming up next week, and it's going to be on the fundamentals of physician assessment. And as you notice, one of our presenters is going to be our own Dr. Steele. So that's going to be a good introduction. If you're not really familiar with what a physician assessment means or how it can be used or why it's important, then I would invite you to join us with that.
Excuse me, may I ask you a question real quick?
Sure.
Are y'all incorporating any type of AI into this program?
Not really, but that is a big topic that we've been discussing, and CPE has been discussing, and I know IAMRA has been discussing, and so it probably is on the horizon. I mean, all of that is just so new, and the best way and how you do it and how you do it fairly. Probably we'll introduce it first in education, just as a way to let physicians know that even when they're using, like automated protocols and things, that they are still the ones that are making the decisions and they're still responsible for them. And you can't just say, well, that's what AI told me to do, kind of thing.
Okay, thank you very much.
And with that, I'm going to turn it back to Dr. Steele, let him finish us up, and then we're both happy to answer any other questions that you might have. Next slide.
All right, this is where I offer and ask a little bit. First of all, there's the offer to please feel free to approach us to attend a K-STAR mini residency graduation virtually, if you have the time and the interest, of course. And Tracy can arrange that for you. It's really easy. They're all done virtually now. There's usually at least 5 to 10 people on each graduation committee, sometimes more, though. We've had more and more interest in it. A lot of faculty from UTMB do participate in the final presentations. Please keep us in mind. We intend on putting our hat into the alternative pathways to licensure because we know we've gained a lot of experience in doing extended remediation periods that allow doctors to both work and to learn at the same time. And we developed enough tools that I believe that we could step right in very quickly and be helpful, whether it's in Texas or the other, I think 10 or 12 states that are currently looking at doing something similar. Now, one thing I want to ask you is if about 5 years ago, maybe a little over 5 years ago, we had a great meeting on reentry here at College Station with a number of stakeholders, including several people from the Texas Medical Board. And we would just like to ask if you would be supportive of convening another meeting on reentry so that we can keep the ball rolling on reentry and seeing what else we could do to help make it better and make it more available to people. This would simply just probably be reconvening a meeting. It could be virtual, it doesn't have to be live. But if you'd be open to that and could be a partner in that, we would really appreciate that very much. Reentry is practical and economic, a practical and economical contributor to physician workforce. And please remember, if you know a pathologist that would be willing to work with us, please let us know because it's a hard assessment to put together. But if we have someone who's willing, we'll do everything we can do to support construction of that and execution of that type of assessment. So I think if you can do the next slide, I think we might be at the end here. All right, does anybody have any questions?
So thank you for that presentation. Really appreciate it. It's always helpful to get an update from your institution, from K-STAR. I was actually at that program in College Station. I think it was 5 years ago. And we got an opportunity to see what you guys were able to offer. I know that as I talk a little bit later on about the Doctors Act, which is House Bill 2038, which is sitting on the governor's desk right now, there will be an opportunity not only to be talking about reentry, but as we, if assuming that that the bill gets signed, there will be obviously a lot of conversation around rulemaking as it pertains to what does the pathway to board eligibility in those provisional years look like? Because my understanding is ABMS is open to that idea as we start filtering physicians through that process. But the other large important part is that there are a large number of foreign medical graduates who probably fit everything in the criteria as far as passing USMLE Step 1 and 2, being licensed already in another country, meeting the criteria and the eligibility of what House Bill 2038 would look like, but they may have been out of practice for several years. And inherently that's not of their own fault because there was no mechanism for them to be able to practice as they have been here. And in many instances, they may be working in other not specialties, but in other entities as other licensed individuals. I know that some of them may be working as surgical assistants or medical assistants, whatever that might be. And there might need to be some kind of collaborative effort to figure out a way how to put them into some kind of reentry program, because again, they would have been out of practicing in their specialty for X number of years, and prior to them being able to be granted an initial provisional license under that new law, that there would be some kind of pathway for reentry that we can have a conversation of what that would look like. So probably more discussion on that as we get a little bit closer to that. I know that Mr. Kokino spoke a little bit about AI. That's something that we are all looking at also, especially as it becomes a larger and integral part of how we deliver care and what the regulatory environment around that looks like. I know we've been discussing that at the FSMB also, which serves as a guide and to offer suggestions to its member medical boards, which we are one of, and to see how that would be incorporated into our regulatory environment. So a lot of good ideas. If any of the other board members have any questions, now's the time to ask.
I have a question. Dr. Steele, you mentioned you may need a pathologist. I may know of someone. If so, how would I contact?
Just Luann, just let Brent know, and we can pass that information along.
Okay, good.
So.
Very good. Thank you.
Thank you. Thank you.
All right. Great. Thank you very much. Thanks for your time.
Thank you, sir.
All right. So the next agenda item, we kind of highlighted one of them just for a second here, which is summary of the 89th legislative session. We just ended that session about a week and a half ago, and there have been several bills that potentially impact or directly impact the medical board. As everyone knows, there are bills that are being passed, and those that affect the medical board directly. We would be going into a rulemaking process into those bills as it's appropriate. So I'll just highlight a couple of them over here. I'm not going to go into too much detail because there's several. There's House Bill 46, which was by Representative Ken King. And by the way, a lot of these have still not been signed by the governor yet. So these are bills that have passed out of the legislature, and some of them are yet to be signed. But House Bill 46 updates on the Texas Compassionate Use Program by, among other things, providing clarity on the proper dosage units and safeguards to ensure patients receive appropriate supplies of low THC cannabis. And I believe there was an addition of chronic pain as one of the additions to the program. And those definitions, of course, came out of our defined metrics from chronic pain and acute pain and so forth that came out of what we had put several years ago. House Bill 2038, which I had briefly mentioned, this was proffered by Representative Oliverson on the House side and by Senator Sparks on the Senate side. It, of course, is creatively called the Doctor Act. It seeks to address onerous statutes that currently prevent certain physicians from providing care in Texas by creating pathways for new physicians to enter the market. Specifically, this bill removes redundant residency requirements for licensed international physicians and creates a new license for medical school graduates who do not match into a residency program, allowing Texas physicians to still benefit from their medical knowledge. The two items I would just very specifically highlight with that, number one is that there is a pathway to board eligibility, which I think is important because as they go through a pathway to eventually become unrestricted licensed physicians, we want to make sure that that there's not a second tier of physicians that does not have that kind of access to board eligibility and potential board certification. The other highlight of that is that the second 2-year provisional license out of House Bill 2038 would be in an underserved area. And that was a very important component of this bill, making sure that as we look at increasing our workforce and our number of physicians out there who are able to provide care, that we did also in conjunction with providing care in areas in Texas where that access is limited. I believe there's about 208 counties in Texas that are classified as critical access counties with a low enough population to where they don't have enough physicians providing care in those areas. So hopefully that will help. House Bill 3749 from Representative Orr, this is also termed Jennifer's Law, establishes new regulatory measures concerning elective intravenous therapy to ensure safe practices and standards within this medical procedure. This is a bill that was unfortunately prompted by a death that happened in the Dallas area in an IV hydration clinic where certain types of therapy was provided and it wasn't properly supervised or delegated to the individual who gave those medications, and unfortunately that ended in a sentinel event where the person who received that therapy passed away. Senate Bill 31 by Senator Hughes. This is the Life of the Mother Act, maintains current prohibitions of elective abortions, but conforms Texas abortion statutes to uniformly define the situation of when a medical emergency occurs. It also codifies that a physician, using reasonable medical judgment, may intervene and provide timely medical care to a pregnant woman in a defined medical emergency. The bill would also protect women undergoing treatment for cancer and other diseases when the treatment may jeopardize the unborn child. Finally, Senate Bill 2480 by Senator Campbell. This was more of a, what we could call, not really a cleanup bill, but essentially it helped kind of close some of the loopholes from one of the bills that passed in 2023, which was House Bill 1998. This was primarily to allow the PHP program to be adequately funded by all licensees so that they would be able to have access to the PHP program. So again, currently all TMB licensees have equal access to Texas PHP, which is the physician health program, but not all licensees were contributing. This bill allows uniform application of the PHP surcharge across all TMB license types and may ultimately allow for the surcharge to be reduced since it can be spread over a larger population. House Bill 1998 allowed for continuous query of the National Practitioner Data Bank for certain TMB licensees, only physicians, but not all. Expanding this to all license types will ensure every licensee receives the same level of monitoring and oversight. Ultimately, this bill creates uniformity across all TMB license types. But more importantly, from a manner of protecting the public, make sure that we are able to access any information that is needed in real time about any kind of disciplinary action that is taken against any of our licensees outside of this agency, so we could potentially act on it. And again, this was a bill that was put forth by Representative Julie Johnson, who's a congresswoman right now, but back then was a state representative, and by Senator Hall on the Senate side. So for 1998, back in 2023, and this new bill by Senator Campbell helps take it to the next level, as I had mentioned. So that is an update on my part. Mr. Carlton, anything else that you wanted to add on that?
I mean, you covered a lot of it. Again, we have a lot of rulemaking coming up, depending on what does get signed, or at least what is not vetoed. The deadline for the governor to veto a bill, I believe, is June 22nd. So we've only got about another week and a half or so, and then we'll know for sure which of these bills are going to become law. So once that happens, then as staff, we'll start working the process of looking at what rules we need to do, what stakeholders we need to engage with. There were some other items before the legislative session that we had kind of put on hold to see what happened during session. So we'll start to re-engage with those also. One of the big changes for us outside of licensing for the international medical graduates and physician graduates has to do with the Life of the Mother Act, which does require us to come up with one or more approved courses regarding the laws relating to pregnancy-related medical emergencies, as the term medical emergency is used in public health provisions of the Health and Safety Code. So right now, the only CME that we've really done has to do with some ethics, and has to do with kind of the rules and kind of going along with our JP exam type stuff for the board. So this will be something new for us to come up with a CME that is different than that. So again, we'll engage with our stakeholder partners to come up with the best program that we can to meet the requirement of the law, assuming that it does go into law. For the IMGs, again, as Dr. Zafran said, it's a 4-year pathway for those individuals. It doesn't change the other pathway. So our other international medical graduates that do get into an ACGME residency can still go through that and not have to do the 4-year pathway. But those that choose not to go that path or have difficulty getting into the residency, they have this other new pathway, again, assuming it becomes law. And the physician graduates, it does create a mechanism for those individuals that have that education to utilize it in a way indefinitely. There's not a limit on how long they can be in the physician graduate license type. It is a limited physician license, but they again can utilize those skills and help them contribute to our healthcare needs. So anyway, that's kind of the big things. And then whenever we get into our budget update, we can talk about the additional resources the agency received this legislative session.
All right. So any of the board members have any questions on the legislative update? All right. Very good. Next item is consideration and possible action for dispositions below minimum guidelines. I don't believe we have any items there. Number 5, consideration and approval of mediated settlement agreed orders. Are there any extractions or recusals on agenda item number 5? Seeing none, is there a motion on agenda item number 5?
Quinones, motion to accept the consideration and approval of the mediated settlement agreed orders.
Second,
Motion by Dr. Quinones, seconded by DeStefano. Is there any further discussion? All those in favor, please say aye.
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 All those opposed, say nay. All right, motion passes. Agenda item number 6, consideration and possible action for remedial plans. There are several items under there: administrative rules, crime laws, impairments, peer review state action, standard of care, unprofessional conduct, and late orders. Are there any recusals or extractions on agenda item number 6? All right, seeing none, is there a motion on agenda item number 6?
Quinones, motion to accept the consideration and possible actions for remedial plans.
All right, motion
Second,
by Dr.
Martinez.
Quinones, seconded by Dr. Martinez. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? All right, agenda item number 6 passes. Number 7, consideration and possible action for agreed orders. There are several items there. You have administrative rules that are none there, crime laws that are none. You have impairments, peer review state action, standard of care, unprofessional conduct, and late orders. Are there any extractions or recusals under agenda item number 7? Seeing none, is there a motion on agenda item number 7?
I'll make a motion to approve consideration and possible action for agreed orders, peer review, state action, standard of care, and unprofessional conduct.
Thank you, Mr. Kokonos. Is there a second?
Second, Quinones.
Seconded by Dr. Quinones. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? Motion passes. Agenda item number 8, consideration and approval for modification request, termination request orders. There are 3 items there. Is there any extractions or recusals on agenda item number 8? Seeing none, is there a motion on agenda item number 8?
I motion, Madam Harrod, that we accept the consideration and approval of modification requests and termination request orders.
Second, Morgan.
All right, you have a motion that's been seconded. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? Motion passes. Agenda item number 9, there's nothing there. Agenda item number 10, consideration and approval of cease and desist orders. There's 1 item there. Is there any extractions or recusals on agenda item number 10? Seeing none.
I'll make a
is there-
motion to approve consideration and approval of cease and desist orders.
Thank you, Mr. Kokonos. Is there a second?
I'll second it, Harrod.
Seconded by Ms. Harrod. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? Agenda item number 10 passes. Agenda item number 11, non-pro-tunc orders. There are none there. 11, consideration and approval of non-protunct orders. And let's see, number 12, consideration and approval of agreed resolution orders. There are none there. Number 13, consideration and approval of consent orders. We have 2 items there. Is there any extractions or recusals on agenda item number 13? Being none, is there a motion on agenda item number 13?
Make a motion to approve the consent order on number 13. Morgan?
Ms. Morgan, is there a second?
Martinez, second.
Seconded by Dr. Martinez. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? Agenda item number 13 passes. Number 14, consideration and approval of determination of default. There is none there. And that brings us up to our agenda item number 15, which is consideration approval of proposal for decisions. We have 2 there, and I will go ahead and pass that off to Mr. Carlton to manage that part.
Yeah, thank you, Dr. Zafran. It is past 8 o'clock, so we can begin the proposal for decision. As Dr. Zafran said, we have 2. For all of our existing board members, you're well aware of this process. Dr. Green, again, welcome. So what we're going to do here is these are 2 proposals for decision that have been prepared by the State Office of Administrative Hearing after a SOA hearing had been conducted for each of these cases. At this point in time, it's the board is going to hear from board staff and from the respondent and their counsel. Each side is going to get 10 minutes to present their case. What they're limited to are the items that were brought up and put in evidence at the SOA hearing. That's what the board has to keep all of their decision-making confined to. And so after both sides present their sides of it, then the board can ask questions and then ultimately make a decision of what to do with the case. And the board has a very wide range of what they can do. And so we will go ahead and get started. And the first one up is Dr. Toe. So is Dr. Toe online with us? Dr. Toe, can you hear us?
I don't see anyone signed under that name. I'm not sure if they have counsel representing them under a different name. Maybe you can use the raise your hand feature in Teams. I can unmute you.
Yeah, this individual might be, I think, is pro se. So what we'll do is, just in case, how about we go to we'll go to the second one, Dr. Cantu. Dr. Toe may be having some technical difficulties. So go with Dr. Cantu and counsel. Sorry. Adjusting on the fly here. You guys both a second to get ready. You ready to go? Oh, okay. Yeah, sure. Give it a minute since like I said, we had a audible here. Ready to go? Okay, you may begin.
If someone's speaking in the room, we can't hear them.
There we go. My apologies. Shane Nelder on behalf of litigation. Thank you for that. Here to present the administrative law judge's proposal for decision. I'd like to reserve whatever time I have left following this presentation for rebuttal. The findings, in fact, and conclusions of law I will be discussing are the ALJs. They are not board staffs. It's not open for debate. We aren't here to relitigate those findings of fact and conclusions of law, only to discuss the final result of the SOA process. This case involves respondent's unwanted sexual touching of a pharmaceutical sales representative in his Laredo medical office while she was there during business hours to provide sample products. Now, all the stuff that I'm going to be talking about are the ALJ's findings, again, not board staff's argument, that this assault occurred during office hours at respondent's clinic. It occurred during the course of the pharmaceutical sale representative's professional duties when she was visiting the respondent in his capacity as a medical provider. When the complaining witness arrived, she was directed by staff to go back to his office, something she had never done before. When she arrived in his office, they discussed products, then the results of her blood work from another provider. And then unexpectedly, respondent began asking about her sex drive, which she was confused about. When the complaining witness gave the respondent a side hug goodbye, something that she had done frequently, respondent became sexually aggressive. Without asking permission, he pulled her toward him, turned her around, and began massaging her shoulders very intensely. He did not stop when she told him he was hurting her. He placed his hands on the bare skin of her abdomen and rubbed his face against her cheek. He then turned her around to caress her buttocks, put his lips to her ear, and whispered something to the effect of, "Give me your love." She then felt that Dr. Cantu attempted to kiss her, but she struggled to get away from him. She fled to his office bathroom, and she waited in there until she heard him talking to a patient, at which time she left the office for her car. Once at her car, she called her business partner, her coworker, her manager, and they all directed her to contact HR. Finally, she called her husband to tell her about respondent's assault. The complaining witness's communication to her coworker about respondent's assault is corroborated by text messages that were in evidence between the complaining witness and the coworker, in which the complaining witness said, quote, "I was just basically sexually assaulted by Cantu. I'm going to throw up, like for real, totally unwanted and unwarranted. It was bad." Now, respondent attempted to call the complaining witness 4 times later that day, but she did not answer. And the next day, the complaining witness and her husband drove back from San Antonio to Laredo for the sole purpose of filing a police report using the written details she had prepared the day before. Now, beyond establishing jurisdiction and notice, the ALJ found respondent's failure to practice in an acceptable manner consistent with public health and welfare, unprofessional and dishonorable conduct, and the acts amounted to indecent assault, a Class A misdemeanor. It involves moral turpitude because it involves the element of violence and reflects adversely on the physician's honesty, trustworthiness, or fitness to practice under the scope of the physician's license. Respondent committed unprofessional and dishonorable conduct likely to deceive, defraud, or injure the public by behaving in a disruptive manner towards licensees, hospital personnel, or other medical personnel, patients, family members, or others that interferes with patient care or could reasonably be expected to adversely affect the quality of care rendered to a patient, and committing a misdemeanor involving moral turpitude. That's Texas Admin Code 22-190.8 2P and R. Now, respondent has argued in his briefing, and I don't know what we're going to hear today, that Aleman versus TMB is controlling. That the board staff failed to prove that respondent's assault was both connected with the practice of medicine and also likely to deceive or defraud the public. I don't know if we're going to hear more on this, but the ALJ already heard this argument and already rejected this argument. And a board staff is prepared to discuss the ALJ's findings upon request, but I won't get into that now. The ALJ found the following aggravating factors: that respondent poses an increased potential for harm to the public because he remained untruthful about his conduct, failed to take responsibility for the harm he did to the complaining witness, and has shown no remorse or regret and has been accused of similar conduct before. Respondent intentionally rubbed his hands on the complaining witness' bare skin, abdomen, and buttocks, and rubbed his face against hers, all without her permission and against her will. He has been subject to 5 previous board enforcement orders, and he has engaged in this inappropriate conduct despite multiple interventions. That's other relevant factors, other relevant circumstances. And so that would be 5, 7, and 9 of the aggravating factors. The board found no mitigating factors. And as far as discipline is concerned, board staff is recommending revocation for lots of reasons, but the ALJ's findings of fact and conclusions of law, the facts alleged, the aggravating factors that were found, and respondent's extensive disciplinary history. He has a 2007 agreed order because he failed to provide the requested medical records and failed to respond to the board's request for records. That's a very minor one, but it starts us off. In August 2008, he failed to complete the CME and found that he had committed unprofessional conduct by failing to comply with that board order. And in October 2013, the board entered another agreed order reprimanding him and requiring him to use a chaperone every time he examined a female patient. JP exam, 8 hours of CME, and risk management. This was after, and these facts are important in this case, the board found that respondent was granted leave by the Laredo Medical Center after hospital staff filed a police report alleging Dr. Cantu's inappropriate conduct with a patient. 2 statements were submitted by eyewitnesses involving Dr. Cantu's alleged boundaries violations, although he denied having any sexual contact with the patient. Then there was another one in 2016 involving a federal charge for prescribing methadone to patients without proper DEA registration. And then finally, another one in June 2020, where Dr. Cantu resigned his privileges at Laredo Medical Center due to an incident that caused a disruption with the patient's family. He was self-referred to Texas PHP and signed a 2-year agreement. Basically, we believe that revocation is appropriate in this case for all the reasons stated above, and I reserve the remainder of my time for rebuttal.
Okay, thank you. You have 2 minutes and 15 seconds left. Dr. Cantu, Mr. Rivas, are you ready?
We're ready. Thank you.
Okay, you may proceed.
Okay. Good morning, board. Thank you for being here. My name is Dennis David Cantu. I reside in Laredo, Texas. I have practiced internal medicine there for 44 years, and I continue to practice medicine in this grossly underserved community. Recently, just put out a study that we have 31% of the physicians that are supposed to be there. And my practice is mostly for lower socioeconomic strata. It's gotten worse as insurances have gotten worse. You know, I grew up in that socioeconomic status, and it was always my goal to return to my hometown to try and undo what I'd seen as I was growing up and what happened to my grandmother, her sister, and my father when they were sick with illnesses. You know, these allegations that have been stated are totally opposed to really what happened. I've seen thousands of drug reps over the past 40-something years, and I've never had any problem whatsoever. In this case, I'd seen this person for a few years, every 3 months when she left off samples. The samples were very important to my patients because they can't afford them. It was a new medication for migraines, and you know, that's why I see drug reps, because a lot of my patients can't afford these new medications. It's also good for them because they get paid for how many doctors they see. So this person...
Excuse me, Dr. Cantu?
Yes.
When you're seeing these reps, do you have a protocol you go by?
Mr. Kokonos, hold on. Mr. Kokonos, I would suggest let the doctor and Mr. Rivas have their 10 minutes. The questioning portion should be you after their presentation.
Okay, sure. Sorry.
Yeah, please proceed.
So going on to the drug reps, we have a thing called the sample room. It's like from here to where you all are at. It's not very, and we have all these samples on these shelves, and that's what I give my patients that really can't afford them, or their insurances don't cover for them, especially like a lot of new medications. So this person came to see me that day and was talking about Nurtec or Aimovig which was for migraine headaches. And she looked at me like this, and her head was like this, talking to me. And I asked her, like, what is wrong with your neck? And she says, well, it hurts a lot. And this was not in my office, as they allege. It was, and I'm not going against the judge or whatever the formal name is for her. It was in my sample room where she always went, and that's where the samples were. We have 3 different levels on each side. And I said, you probably have a trigger point. And she says, what's a trigger point? I said, if you allow me to touch your shoulder and your neck, I'll show you. So I took 2 fingers and just put them right in the middle of her trapezius, which is her shoulder here. And she says, hey, how did you know that was there? I said, well, that's just what I do. So I went to the medication room, which is right across the hall. There were no doors were closed. The staff was going back and forth. I gave her 2 extra strength Tylenol. And I told her, I said, if you have any further pain, let me know. And I will get a chiropractor for you in San Antonio, or I can send some anti-inflammatories for you. So from there, we went to the common area where all the staff was there. And they knew her because she ordered Starbucks, but she didn't hide in any bathroom. She went where the staff was. And I told one of the staff, said, you know what, go get her two a leave. I just gave her some Tylenol. So she went over there, and in front of the staff that was there, one of which testified, I pointed, I said, do you mind if I show them? Because I was trying to educate my staff. I said, look at this. And she went like this. And just when I touched her shoulder, that's all I touched. During this hearing, she faked a Heimlich maneuver. In my life, I've not done a Heimlich maneuver to anyone. I swear on my 4 grandchildren, I just had one a month ago. I swear on them, I've never done a Heimlich maneuver on anyone. She alleged that I put my hand up her blouse and touched her breast. That is just absolutely not true. My staff was right there. This did not happen in my office. It was in front of my staff. And one of them testified. She was a former member. There was one other staff member there, but we couldn't put her there because they said, well, you paid her to do that. This one had left 2.5 years ago to become a nurse. And she was an excellent one that I taught a lot to. And as far as touching her face, never. It was right in the middle of COVID. I lost 60 patients in my practice from COVID. Everyone had a mask on. I didn't try and kiss her. Everyone had masks on. Everyone had to have a mask on during COVID. This was 4 years ago. And then she sat there and was with the staff. She didn't leave anywhere. She sat there and staff, and they laughed with them, and she ordered Starbucks for everyone. That is the truth of what happened. But of course, I fully understand the reason for today's meeting. The ALJ, is that her name? The ALJ went, believed her, and I understand. I'm Hispanic. I'm a male. I'm older. The Me Too thing going on right now is gross to me. I hate to see it every day. I can understand what happened. But like I said, I'm Hispanic, I'm a male, and I'm older, but I love what I do. Besides my family, it's the most important thing I do. I went back there. I take care of patients. Look, I have a clicker in here. My patients call me all the time. The cancer patients, this is how I give them controlled substances on my computer that I carry with you. All my patients, when they come to my office, the very first visit, they have my cell phone number, and they call me all the time. That's my wife. She's right behind me. They call me all the time. But Saturdays, weekends, I don't care if it's Christmas, New Year's, whatever. They have my phone number in case they don't. A lot of them can't afford these urgent care clinics. A lot of them don't want to go to the emergency room. On Sundays, after church, I go to church at 10:30. After church, what I do is I do house calls. This past Sunday, I did 3 of them. These people can't get to the hospital. And, God granted me the privilege of doing what I do. And I do it back for them because I grew up in that community. And I know what it's like when you can't afford a doctor. I care about my community. I was on the school board for 17 years. The first health science magnet school in that city was named after me. And I don't mean to brag about it, but I did a lot for it because I didn't have that type of education. I also, when I got back, I trained in Houston. I trained in Los Angeles. That's where I did medical school and ERs. And I know when I got to Laredo, there's no EMS. There were just a funeral homes going up and picking up people, put them in like it was just a wood wagon. I started the EMS. I used to lecture them in my house when there were 10 of them and the fire chief couldn't stand an EMS. It went from 10 to 200, and we went from 2 ambulances to over 15 right now. I care about my community, and I care about the people I see, and I've never, ever done that. I swear on my children, I've never done a Heimlich maneuver on anyone. I have never inappropriately touched that. And he goes back to this 2007 insurance episode. It was a patient of mine suing an insurance agency. The lawyer that filed this was her, and she's still my patient 30 years later. I take care of her mother and her grandchildren. Her insurance filed because they didn't get the copy of the medical record. The girls at the office hadn't sent him. And we sent him in, and he was fine. He wanted to drop it, but he said, no, you already filed with the board. It has to go on. The board gave me a list of CME I could do. So I went and did one. When I got back and I filed, they said, well, look, we gave you this sheet, sure, but you had to call us first to approve which one you chose. That is why that second one is there. And they made me do another one. I've always complied with what the boards tell me. The thing about the chaperone, that patient, that was the third time I saw that patient. She was a heroin addict, cocaine, IV drug user. This was the third time I saw her. The second time I had her on a ventilator. We didn't have a pulmonologist. I took care of her on a ventilator for 10 days, got over it. And then like the first 2 times, she signed out against medical advice. This third time, I didn't want to take care of her because she was psychotic from what the ER doctor told me was cocaine, heroin, methamphetamine, and pot. I did not want to take care of her. I tried to get her into Cocaine Anonymous the first time. She didn't want to go in. My wife right here, because she knew the patient's parents, said, please take care of her. She's sick. I took care of her. They called me from the floor. She was psychotic in the hall. I took her down, laid her down, sat there and tried to convince her. Then they accused me of being inappropriate with her. She had vomit all over her. And she was screaming for IV Valium. I didn't give it to her. So she signed out against medical advice. Okay. The other one, the methadone heroin thing, I have done more free care for emergency room in Laredo than anyone else. I did it for 30 years. I had all these heroin addicts. Before it was, all that fentanyl and stuff was going in the East. Okay, my time's up. They got me. Okay.
The board has a duty to be fair and consistent. As the board knows, the Occupations Code states that the ALJ cannot make any recommendation regarding the appropriate action or sanction. We all know that. The board's staff recommendation for revocation, in our view, is excessive. We reviewed the board decisions on boundary violations for the last 20 years. There's not been one revocation where there was not a companion criminal conviction. Also, we had Dr. Cantu evaluated by a psychiatrist here in Austin, Texas, Dr. Corrado. And
if you can wrap up real quick, I'll give you like just another 15 seconds or so.
Okay, that's all I need. Okay. Dr. Corrado, who's actually here and available, evaluated the doctor in May and found that he posed no risk whatsoever to patients.
Yeah, I would object to that.
Outside the record. Okay.
But here's the important thing. The board needs to be consistent. The board's never revoked a doctor for a boundary violation absent a criminal conviction in the last 20 years, and we ask that the board remain consistent.
Okay, thank you. May proceed.
Thanks. Am I on?
Yeah, you're on.
Okay, thank you. A lot of what we heard before has already been discussed during the hearing on the merits. There was testimony put on by both sides, sworn testimony. Inconsistent testimony by respondent and his former employee, who not only testified that a lot of things happened in front of her, but that they were never actually in a separate room. That even contradicted his own testimony that they were together alone without anybody else in the sample room. Nevertheless, the ALJ has found that the complaining witness and the respondent were alone in his office. So all these things that we're talking about, it's already been established, and we're not here to retry the case. We're not here to debate those kind of things. As far as the appropriate measure, disciplinary action in this case, these are very serious allegations that affected the complaining witness's life. This individual, this respondent, has had multiple times. Now, I'm not discrediting any of the other work that he may have done, but when we're talking about an individual who has been disciplined by the board multiple times, has resigned his privileges or been disciplined by hospital entities because of questionable, and I can't get into it, and I won't get into it, activities with patients. One thing that we heard throughout this is that it was never me. It was always those people. The other person had issues. It wasn't me. We hear this a lot when we hear about physicians who have boundaries violations. It's always the patients have anxiety. The patients misunderstood my actions. These actions should not be misunderstood. This was not the simple touching of a trapezius muscle for therapeutic purposes. This was a sexual contact, and the complaining witness got nothing from this. She showed up and she testified so that this wouldn't happen to somebody else in that community that he serves. Thank you.
Okay, so I'm going to allow the board members to ask any questions, but let me just offer one word of caution. We are only limited by the ALJ's findings. I do not want to get into a conversation about the specific issues and the circumstances surrounding the case that go outside the ALJ's findings. We are statutorily confined to those ALJ findings, and the only thing that we are allowed to do right now is to determine what any kind of potential sanctions or non-sanctions there are out there. So please limit your questions to just that. All right? Okay, are there any questions from the board members?
I have a question.
Dr. Jones?
Yeah, Dr. Cantu, in looking at the ALJ statement, I'm looking at bullet point 25 under the December 14th incident. It says you made 4 phone calls after the pharmaceutical rep left your office. Why did you call her 4 times? I'm sorry, I'm having some audio trouble
We can't
here.
hear.
Oh, okay, sir.
Need to start over.
I did not call her 4 times on that day. What happened, any of my patients that have headaches, any
I'm
kind
sorry,
of severe,
but this is already findings of fact, right? So we're not
but
arguing
it wasn't
whether
a
or not
finding
you
of
called her
fact,
4
sir.
times, right?
I called her the next day. One, it didn't, no one answered. So I told the girls at the office, because they had a card. What was her number again? I want to see if, like I said earlier, and I told her, and I think it's in the record, I want to see if she needed a chiropractor or more anti-inflammatory medications. That's the only reason I called. That's the only reason I called. That's the only reason I call all my patients.
So you called her 3 times in a
Twice the next day.
45-minute time span to ask if she wanted
That
more
is not
Tylenol?
correct. And if you go through the evidence there, they didn't find that number anywhere in there. I called her twice the next day.
I'm looking at number 25, and these are already facts that we've all agreed on, correct?
Dr. Jones, just
No, I disagree with those, Dr. Jones. I called her twice the next day to see how she was doing and to reinforce what I told her earlier, which is if you need a chiropractor or more anti-inflammatories, we can arrange it for her. She was seeing a nursing practitioner who she didn't trust.
Can you talk about just a little bit where that finding came from?
In brief, that came from the complaining witness herself, and there was some discussion how that wasn't found anywhere in the records. We had a big to-do about the telephone calls that were made to and from those numbers because the phone records were requested so much later that the actual untaken calls were not reflected in the phone record, including the call that respondent claimed to have made the next day. No phone records were shown. Respondent admitted that he called her, but that record isn't in there. Respondent or complaining witness said he called me 4 times the same day. And I think we knew why that was the case, but the implication was trying to claw back what he had done. But it wasn't in the record. However, there is an admission that there were calls, but no calls were reflected in the phone records because we requested them more than a year after the phone calls were made, and those calls were not taken. It's like a Verizon phone record issue.
Okay.
Any other questions? Okay, so traditionally speaking, or typically speaking, what we do is to go into executive session for further deliberation. So I will entertain a motion to do that.
And Dr. Zafran, let me just jump in quickly. From a procedural aspect, obviously, yes. We normally do if it's necessary. If it is not, and if any of your board members wish to tender a motion right now, that can also be done. So I just throw that out there. It's not required, but again, as has been said, the findings of fact are the findings of fact. They're established, whether or not somebody disagrees, or the rationale, or any dispute that happened or that was tried within the SOA proceeding. It is established by the judge's finding, whether or not Mr. Rivas, Dr. Cantu, Mr. Nelder agree or disagree with some of the findings. Quite frankly, at this point, makes no difference. The judge has established that, and what the statute says is, and Mr. Rivas articulated it quite well, the board has the full and total discretion to decide what sanctions, if any, they may want to establish. But you cannot change a finding of fact, and you cannot change a conclusion of law. So I just throw that out there as a little more reinforcement, Dr. Zafran. You're kind of an old pro at doing this, but some of your board members haven't done quite as many PFDs.
Thanks, Scott. And, primarily the purpose of going into executive session, and I would encourage that, is really more to discuss, what the board wants to do. As I mentioned earlier, and as Scott mentioned earlier, we cannot change the findings of fact. And really, it's primarily a discussion as to how we want to proceed, because that is where we do have discretion. So, with that, if someone would like to entertain a motion.
I'd like to move we go into executive session. Martinez.
I second Morgan.
Okay, so we have a motion and it's been seconded. So we're going to go into executive session for the following reasons. Deliberations concerning disciplinary action, investigative information, peer review information, and possible rehabilitation orders under the authority of the Medical Practice Act, sections 152.009, 160.006, 160.008, 164.007C, and 165.202 to 165.203 Occupations Code. While in executive session, the board will not take any action, make any decision, or vote with regard to any matter that may be considered or discussed. A certified agenda of any executive session will be made.
Okay, the time is 9:23 a.m. And so virtually we'll start removing individuals that are not privy to executive session, and if we can clear the room also. Thank you.
Okay, it is 9:49 a.m., June 13th, 2025. We are out of executive session. While in executive session, the board did not take any action or make any decision or vote with regard to any matter that may be considered discussed. And as I mentioned earlier, a certified agenda of the executive session will be made. Now is the time for any kind of deliberation between the board members regarding what your final action or potential motion might be. Are there any comments by the board members at this time? Is there a motion out there, Dr. Quinones?
Yes. With regards to Texas Medical Board versus Dennis David Cantu, proposal for a decision based on the findings of fact and conclusions of law, I move that we accept the recommendations from staff on license revocation for Dr. Cantu.
A motion's been made by Dr. Quinones. Is there a second?
Second, Jones.
Seconded by Dr. Jones. Is there any further discussion? Seeing none, all those in favor, please say aye.
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 All those opposed? All right, the motion passes. All right, thank you very much.
Dr. Safran, just one question. The doctor has patients already lined up for Monday, and I'm wondering for the issue of patient safety, he's going to need some time to transition these patients to another provider. And so is there room or an opportunity for the doctor to, I guess, have a little bit of time before the revocation becomes effective?
Well, Mr. Rivas, as you know from procedure, obviously that once the order is effective today, of course, you have 30 days to file a substantial evidence appeal, but the effect of the order is immediate. So there's not extensions given. Obviously I can't give you or your doctor advice, but there needs to be arrangements made for either transferring these patients or if any are needing bridge medications, say for the next 30 days for, chronic medications, that needs to be addressed immediately. But basically, as of the meeting and of right now, he is, according to the board motion that just passed, his license is revoked. He's technically can't practice medicine. If he wants to be sure refills are done today to bridge for any of his patients, that's fine. If they have existing refills, that's obviously not a violation because they pre-exist the revocation. But there's no accommodation for transition, wind down. He just needs to take immediate measures to ensure patients are covered by a physician in some form or fashion.
Board, there are some patients that have biologics for lupus or psoriatic arthritis for cancer, and they don't come due, but every 30 days, we will not give it to them.
You're going to have to make the arrangements, doctor. I'm sorry. The order is entered as it is, and that is the effect of it. I understand your concern. Make the arrangements for those patients, even if it's, whatever it takes. But if they're established patients, get the transfers done and get the care going. But there is no transitional period that's allowed in these particular situations. Hold on just a moment. I'll tell you what, Mr. Rivas, if you all want to hold on just a couple minutes, I want to look at something. And if that's okay, Dr. Safran, why don't we do this? You've made that motion, but I ask, have your board take a 10-minute break right now. I want to look at something quickly. Mr. Rivas, I would ask if you remain, here at the table. We'll be back in about 5 or 10 minutes.
Sir, can I have 5 seconds of your time?
No, sir. We're done right now.
I would suggest let's just wait. It's 9:54 a.m. right now. Let's go into recess until 10:05 a.m. Alrighty, it's 10:05, so we're going to go ahead and go back into session. Mr. Freshour?
Yes, thank you. And Mr. Rivas, are you there with Dr. Cantu?
Yes, we're here.
Okay, and thank you for asking that. I knew there was something in my mind, and I got my team to look at it. And this, for board members also, this is a reminder. This is one of those points that we all know, but we tend to forget. You do, Mr. Rivas, by law under the Administrative Procedure Act, the order that the board is entered today is effective either by when you file a motion for rehearing and the board rules on it, or if you fail to file the motion for rehearing, it would become final that day and fully enforceable, unless the board said in this order, which they adopted, says this is immediately effective. Now, in Dr. Cantu's case, the immediately effective language is not in the order. Therefore, Dr. Cantu, the final effect of the revocation is going to be contingent upon the timing of a motion for rehearing, if it is filed and if it is overruled, or if you do not file it. So you need to go look at the APA. It's 2001.144 of the Texas Government Code. Will explain those timelines. So what the conclusion is, board, and this is the way you've always done it. It's just one of those things that I should have known, but it's such a force of habit. I had to actually go back and look at the section. It says, unless in an agreed in a final order, you write in this order is immediately effective, the respondent is allowed up to 25 days to file a motion for rehearing. And you all are familiar with the motion for rehearing procedure. If the doctor doesn't file one at 25 days, he has to stop practicing. If he files it within that 25 days, as soon as you rule on it as board members, and you always get a request to whether or not you want to grant the rehearing, if you decide you do not want to grant it, as soon as a majority of you make that vote and notify the board staff, then the order would become effective. So the long and short of this is this will become, because the language is not in there today and you've already adopted it, what he has is basically about a 25-day wind down period within the Administrative Procedure Act before this order will become final, where the revocation is fully enforceable.
Okay, thank you for that, Scott. So
yes,
I think that answers your question.
Thank you, Mr. Freshour.
Yep.
All right.
Yes, of course. If you have a question, Mr. Rivas, you know where to find me, and you can call me later if you need to. But I think this is self-explanatory, and I appreciate you asking, because it just triggered us as lawyers to go back through and refresh ourselves on exactly what we know, but sometimes we can't point to it exactly.
Understood. Thank you, Scott.
Okay.
Yep.
All right. Thank you. All right. So moving to the next item on the agenda
we'll have to still go back to Dr. Tu.
That's correct.
Yeah.
So let us go back to the first PFD, which is Dr. Tu.
Dr. Tu is still not physically here with us. Has Dr. Tu?
And it is Toe.
I'm sorry. Sorry. Thank you, Dr. Toe. I think I said it right the first time. It's around it's Dr. Toe has joined us online.
I did reach out to him.
Go ahead,
I did. Oh yeah, I did reach out to him over email when you were in executive session a little bit ago, and I have not received a response.
Okay, well, we will go ahead and proceed then without Dr. Toe.
All right, good morning, board members.
We still have to limit it to 10 minutes though, so if we get the clock up. There we go. All right, you may proceed.
All right, thank you. Good morning. My name is Meredith Massey. I'm one of the staff attorneys in the litigation department. This case involves a prescribing error, actually 2 prescribing errors, starting back in 2021. In 2021, and you'll have to remember that this is the height of the COVID pandemic, a mother brought in her 20-month-old child to Houston Medical ER for coughing, sneezing, fever, runny nose, and lethargy. The nurse weighed the patient on a scale that was in the clinic, and the 20-month-old weighed 23 pounds or 10 kilograms. Dr. Toe evaluated the patient and diagnosed upper respiratory infection, unspecified. Dr. Toe prescribed 2 medications for this 20-month-old, ibuprofen and prednisolone. There are problems with both of those prescriptions. For the ibuprofen, the prescription that he wrote called for 11 milligrams every 6 hours. For the and let me let me talk about the ibuprofen. That's a pretty significant overdose. That is actually twice what should have been prescribed. Now, before the mother dispensed this medication to her child, she noticed that it seemed a little high, so she did call the pharmacy, and the pharmacist did confirm, oh yes, it should be for 5.2 milliliters every 6 hours, not 11. And what it was determined was that Dr. Toe wrote the prescription for 23 kilograms instead of 23 pounds. 23 kilograms is approximately 50 pounds, and you have to realize that he examined this 20-month-old and made no note in the record of her being a very large child for 20 months. So there was a calculation error. With the prednisolone, there is no known indication that prednisolone should be used to treat an upper respiratory infection. The patient's mother dispensed a dose of prednisolone to the child. So in 2022, the board received a complaint against Dr. Toe. Dr. Toe was invited to an ISC, but he refused to attend. In 2023, the case was referred to SOA. Dr. Toe was unwilling to go to mediation. This case was convened on the default docket at SOA. Dr. Toe failed to appear, and the ALJ issued a default dismissal order. A few weeks after that, Dr. Toe filed a motion to set aside default and was granted. So in 2024, the matter was reassigned and did proceed to a hearing on the merits in May. We had the hearing on the merits. After the hearing, but before a briefing was due, Dr. Toe terminated his counsel, and he has continued self-represented since then. Now, in 2025, the ALJs issued, the one single ALJ issued a proposal for decision, including findings of fact and conclusions of law, as you know, and the ALJ did find violations. I'd like to draw your attention to a few of those specifically. Finding of fact 39. There may be increased potential for harm if respondent continues to calculate prescription dosage amounts incorrectly. Number 41, respondent did not self-report his conduct. Number 42, respondent was unwilling to cooperate with staff. Number 43, respondent has diminished rehabilitative potential due to his unwillingness to cooperate with the board to address or resolve this matter. I'd like to draw your attention to a couple of conclusions of law. Number 6, the ALJ found respondent engaged in unprofessional conduct that is likely to deceive or defraud the public by prescribing ibuprofen in the wrong dosage. Number 7, he also engaged in unprofessional conduct likely to deceive or defraud the public by prescribing prednisolone in a non-therapeutic nature for the manner it was prescribed. Number 8, respondent failed to treat according to the standard of care by over-prescribing the ibuprofen. Number 9, respondent engaged in negligence in performing medical services by misreading the patient's weight and calculating the dose of ibuprofen. Number 10, respondent failed to use proper diligence by overprescribing. Number 11, respondent failed to safeguard against potential complications by overprescribing. Number 12, respondent failed to treat according to standard of care by prescribing prednisolone with no known indication. And number 13, failed to use proper diligence in professional practice by prescribing the prednisolone with no indication. So all of those were already established. They were found, determined by the ALJs. There were actually also some aggravating factors that I'd like to draw your attention to. The ALJ did find that the board may consider increased potential harm to the public and other relevant circumstances increasing the serious. And that's kind of, as you know, what we're here today to talk about. There may be increased potential for harm if Dr. Toe continues to calculate prescription dosage amounts incorrectly. That's pretty obvious to see. Dr. Toe's unwillingness to cooperate with board staff's investigation also constitutes relevant circumstances increasing the seriousness of misconduct. In the proposal for decision, the ALJ went out of his way to include 2 email messages that Dr. Toe sent to board staff. This is indicative and illustrates Dr. Toe's lack of cooperation. I'd like to just read you a couple lines from that from May 20, 2023. Dr. Toe said to board staff, "Please do yourself and me a huge favor and write this off as a clerical error. Nothing is more wasteful than proceeding with this frivolous complaint. That is all that I have to say to you at this point. Thank you for bringing this to my attention. Complaint about Motrin weight-based dosing error noted." When Dr. Toe was asked about availability for mediation, Dr. Toe wrote back to board staff, "You were the one who pushed this frivolous case through to SOA. You started it, you can end it. There is no need for a mediation and wasting everybody's time. I will not sign any mediation order coming from you or SOA over this frivolous complaint. You can stop wasting your time and taxpayers' money. I would spend $1 million to fight this through the court system, all the way to the state Supreme Court if I must. Hopefully there will be a judge with the gall to drop this case, as it will waste the court time as well." The judge found no mitigating factors, and in fact found the opposite of a mitigating factor in that, based on his demeanor since receiving notice of violation in 2022, Dr. Toe appears to have diminished rehabilitative potential. Board staff has recommendations for discipline. The ordering paragraphs in the drafted final order are based on the sanction guidelines. 1, public reprimand. 2, 24 hours of CME. 3, JP exam. 4, $2,000 administrative penalty. The CME is 8 hours in ethics, 8 hours in indications for prescribing corticosteroids in pediatric patients, and 8 hours in pediatric prescribing pearls. Dr. Toe made mistakes with this patient, and yes, thankfully, the patient is okay. But we're here because this is about protecting the people in the state. Board staff is concerned with Dr. Toe's increased potential for harm if he makes the mistake in calculating dosage amounts again. And throughout this process, Dr. Toe has been quite uncooperative with board staff and frankly has shown a lack of respect for the board's authority to enforce the Medical Practice Act. So board staff requests that and recommends that the board adopt the final order as drafted. Thank you.
Thank you. And I'm presuming that we're going to give the other side the opportunity. They're not here, I'm presuming?
Yeah, kind of last chance. Dr. Toe, if you're online, this is your last opportunity to say something before the board asks any questions of board staff. They're the only ones to ask should they have any, and begin deliberating what to do based on this proposal for decision.
I did send a reminder email to him 36 minutes ago. and I have not received any response.
And
Well-
he did receive notice of all this
Correct.
well enough in advance.
Well, there seems to be a history at kind of
Yes, Dr.
not
Dexter.
necessarily appreciating or understanding the charge that the board has in protecting the public and its ability to enforce the laws. And I understand that there may be some questions or concerns about whether a dosage is that big of a deal or not. Well, I mean, when it comes to infants, it is a little bit of a big, well, it is a big deal, especially when you double the dosage with something that can affect the kidneys as ibuprofen potentially could. But it's obviously something that could have been rehabilitated and potentially looked at had there been some level of cooperation from the respondent. And I think that kind of brings us to something that really concerns me even more, which is this cavalier attitude of I really don't care. To me, this is my opinion saying it. I don't care about what you think was appropriate or not. I think it's frivolous, and do as you wish. When it comes to patient safety, when we talk about infants especially, that's not the kind of attitude that I believe is conducive to patient safety. Because if it's about a dosage of a medication that, if given, potentially may have been okay or could have created harm, the question with that attitude is, what about other things in the practice of medicine? And does that cavalier attitude kind of continue on? So I have a lot of concerns about this. I have a lot of concerns that he's not here, that he's been unwilling to participate in the process, especially in a court proceeding, as SOA is. This is not a small, trivial thing, but he seems to be taking it as such. And again, that concerns me. So anyway, interested in hearing any of the concerns or viewpoints of our board members.
Or if anyone has a motion to accept staff's recommendation. Dr. Quinones?
Thank
Go
you.
ahead, Manny.
Yes, I share your concerns, Dr. Safran. I have serious reservations as to the order. I don't think he'll honor the order and recognize the order based on the fact that he's been so cavalier and disregarded all the other invitations to participate in the process, and seems to not understand the gravity or the importance of his participation. So I seriously don't think that he'll participate or recognize the order or follow the order, and we're just going to be back here again with the same problem.
Well, no, I don't think it'll be a problem, Dr. Quinones, because if he doesn't comply with the rules of the order, then he may not have a license to practice anymore. So all we can do is just address the issue at hand, and look at the proposed order. We can decrease it, we can increase it, we can go by whatever's recommended. He will have his opportunity to comply, and if he doesn't, we will go to the next step.
Dr. Martinez, then Dr. DeStefano.
Understood.
Yeah, I kind of echo what Dr. Quinones said. What Dr. Safran just said, in infants, it's particularly more dangerous to knock off a kidney or a liver. And, the cavalier attitude bugs me a little bit. I fear that any order we put out is going to nub his finger at as well. You know what I mean? And I wonder whether we should actually do more than what the recommendation is in this case. I'm a little concerned that and in the meantime, for that process to play out, there's going to be more serious consequences potentially.
So just to that question, Dr. Martinez, Scott, what is the timeline of compliance here?
Well, and again,
with a potential order. So let's say that we adopted this order here, for example.
Yes, of course. Well, there's two things. Obviously, like we just spoke with Dr. Cantu and Mr. Rivas, his lawyer, if you were to adopt this order today, Dr. Toe would have the ability to file motion for rehearing. If he doesn't, then the order would go into effect that day. The reprimand would be, the reprimand, the CMEs, the fine would come due and whatever time periods were associated with them. If he did file a motion for rehearing, again, you will get notice that he's filed a rehearing. Here's what he's saying should be done, and you can vote yes or no. And if you don't grant the rehearing, then the order will go into effect, and he still has his appellant right. But at the 25th day, which is the day that the motion for rehearing is filed, that is the determinative day where we would start enforcing it, because then the order is final and enforceable. So we would have 25 days. Now, once compliance gets it, and Mr. Palazzolo can jump in, but they will contact him immediately and say, this is what the order is, et cetera, you need to comply, and they'll start running timelines. And if he were to say, go jump in the lake, as you said, Dr. Zafran, that's an enforceable action where he could be brought in for violation of his board order. And that's a whole separate enforcement case, and that kind of thing. The other thing, and I can say this, is when you're talking about the sanctions, you do need to be mindful, and if need be, we can go into executive session, but you need to be mindful of the what I'm going to term proportionality relative to the violation and the history. Is that appropriate? Because if it is a disproportionately restrictive order, I'll use the extreme example. If you were to say, let's revoke this gentleman, I would submit to you that more likely than not, if he were going to appeal, you've got potentially a problem because it's beyond the scope of what's necessarily being found. Now, you can have these concerns over whether or not he'll thumb his nose at us. But again, that is purely speculative. So you need to take this case on what it is. Is this something that is in line with a normal sanction? But you do have mechanisms if he does tell you to go jump in the lake.
Okay. Thanks, Scott.
Thank you. Yeah.
Anyone else?
Yeah. Dr. DeStefano, then Dr. Jones.
Yeah, I was just going to say I agree with, I think personally I would be agreeable to accept the staff findings on this one and recommendations, and then see how he responds. And if he responds as predicted, then we can take that extra step up to possible revocation. My 2 cents.
Dr. Jones?
I'm kind of thinking along the lines of, I understand that this licensee has, not been cooperative with the investigation and even sent some, kind of provocative emails to our board staff. But I do kind of want to take a step back and, thankfully the patient wasn't harmed. It's an important error that should have been noticed. I don't see any, and Scott, please, stop me if I'm out of bounds here. I'm unaware of any previous board history, although we are talking about just what's in front of us. Is that appropriate to say?
Yeah, but I mean, Dr. Jones, we can let board staff answer that question for you.
Okay. Does this gentleman have any previous history with the medical board?
Yes, Yes, Dr. Jones. In 2009, Dr. Toe did enter an agreed order with the board. He paid an administrative penalty of $1,000. It was he was not spending the required 20% at an alternate practice site. And he also was found to not be adequately supervising providers practicing under his supervision.
Okay, I appreciate that. Thank you. And yeah, I want to make sure that we're not being disproportionate. And even I'll use the word vindictive here. So I'm leaning more towards a little less than what the proposed staff order is here.
And again, and Dr. Zafran and Mr. Carlton can certainly do this, but as Dr. Zafran said, once this discussion is over, and I think this is very good, and it's good to have it right here, is he will seek a motion, and it's going to be just like we do in our committee hearings, and get a motion, see if there's a second, and he'll take a vote. If that vote doesn't pass or something like that, there's got to be an alternative motion because you've got to dispose of this at some level, one way or the other. The only thing I would remind you is ultimately when you do get to the motion portion, you will be adopting the findings of fact and conclusions of law because again, you can't change those, and there's certainly no basis for you as a board, I'll tell you right now as your general counsel, to try to appeal those. So you're really looking then at the sanctions. But again, Dr. Zafran, as I've said a couple times today, as an old pro at doing these motions and guiding you as a board through how this process works.
All right. Any further discussion? All right.
I'm Dr. Naidu. I
Dr.
think
Naidu.
when the patient came to the ER, they record the weight. Probably they did, instead of the pounds, they put in the kilograms. That led the physician to give the wrong dosing. But still, the fault lies with the physician. The fault is there. You can look at the patient and say, there's a 24 kg or 24 lb. Just by looking at it, there is a mistake done. We have some sanctions given by the staff. I still think we should go with it, the same sanctions.
Yeah, when we're talking about pediatric patients, and there are many of us who, as an anesthesiologist, I deal with pediatric patients all the time. And there are things that are called never events, because when you're dealing with certain types of medications, the difference between one dose and another can be lethal. Not just something that can create irreversible harm, but it can be lethal. So it is our duty to make sure that the dosages that we give, it's not a trivial thing, it's far from trivial, is appropriate. For an adult, it's a little bit more forgiving, but for a 20-month-old, it is not. Because again, that is the difference between a lethal dose and a non-lethal dose, and all of us have been taught, to make absolute sure that these dosages are correct. Luckily, here you had a mother who apparently was, intuitive enough to ask that question. So that safeguard was there. But it's all about that Swiss cheese analogy where you try to prevent harm at different stages, but if all the holes line up and a sentinel event happens, then harm is created. So it is something that we got to be very careful of, and it's something that we have to be always reminding our respondents of. And what I would say, and again, I kind of said this at the beginning, had this been taken care of at an initial type of hearing, I think all the conversations we're having as far as mitigating circumstances, a first-time error, whatever that might be, would be appropriate. But I think the fact that there is a I don't care and this is frivolous type of attitude really goes back to the issue of public safety. This is not about being vindictive at all. I don't take this as being vindictive. I take this as being part of the problem. Because if you don't care about this and fixing this problem, what other issues out there do you consider to be frivolous to the point that those holes in that Swiss cheese line up and potential harm is created? So that in itself, to me, is part of the concern that I have with potential other harm being created moving forward. And I think that needs to be part of that conversation. It needs to be part of the discussion, especially as you're talking about infants, because the margin for error is not there anymore. It's non-existent. And I think the opportunity for remediation probably was about 2 years ago, when there would have been a willingness to remediate, which kind of goes back to another issue. In order to remediate, you've got to want to remediate. You've got to be willing to. If you have a lack of willingness to remediate, that's part of the problem. And I think that's part of what we have to be addressing over here. And in my opinion, the order as written is proportionate and appropriately addresses not only the initial issue, but the cavalierness that has been taken since then, which, to the point that Mr. Freshour always says, has been noted by the ALJ. So it is part of those findings of fact. It is part of what we are looking at over here. So anyway, with that, is there a motion, or is there any other further discussion?
One quick question for staff. Was this case ever up for dismissal prior to now?
That's outside the record.
Okay, thank you.
Dr. Jones, you got to remember, this is a SOA record. I know it's tempting because you're used to being far more wide-ranging, particularly at ISCs
I
and
appreciate
DCRC, but again,
thank you.
it's
Then
tough
I'll
to
withdraw that.
change hats.
Yeah, thank you.
Dr. Quinones.
Yes, sir.
Would you like to make a motion, please?
Yes, I will make a motion. But before I do, I just want to say that I concur with your opinion with regards to the cavalier attitude. And I would, Scott, is it within my ability to add to the order or to add to the enforcement with regards to
Yeah, I know what you're asking. What you would do is make a motion to adopt the findings of fact and conclusions of law and the board staff's recommendation, but add blah, 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 blah.
I'm gonna add some strong blah, 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 blah.
Well, whatever your blah, blah, blah is, you can put it in there and see if your fellow board members agree with you or not. And again, that's the motion process. That's the discussion. It's good to have it here and, you know, let the public see how much work you all put into this and how thoughtful this board is.
Thank you. I'm prepared, Dr. Zephyrin.
Go ahead, Dr. Quinones.
No, I'm prepared. I will add when we come back into session, I will add a.
We are actually in session.
Yeah,
we never went out.
Okay. Therefore, I make a motion. I would like to make a motion with regards to, excuse me, let me get back up to where I'm supposed to be. In the matter of the complaint against Brandon Nieto by the Texas Medical Board, based on the findings of fact and conclusions of law, I move that we propose the order as outlined by staff. In addition to that, I make a motion that Dr. Toe be required to appear before a disciplinary panel within the next 30 days to explain his response or lack of response to board orders before he can continue to practice.
I would recommend that I think we better go into executive session if you think that is going to be your motion, Dr. Quinones.
Let's go. I would move, we go into executive session.
So okay, are you withdrawing your current motion and entering a new motion to go into executive session?
I'll withdraw my current motion and move that we move into executive session.
Okay, so the motion's been made to go into executive session. Is there a second?
Second, Morgan.
Seconded by Ms. Morgan, and I think by Dr. Martinez. Yeah. All right, so we will close the meeting to the public and continue an executive session for the following reasons. Deliberations concerning disciplinary action, investigative information, peer review information, and possible rehabilitation orders under the authority of the Medical Practice Act, sections 152.009, 160.006 through 160.008, 164.007C, and 165.202 through 165.203 Occupations Code. While in executive session, the board will not take any action, make any decision, or vote with regard to any matter that may be considered or discussed. A certified agenda of any executive session will be made. We will go into executive session at 10:40 a.m. on June 13th, 2025.
Yep, no, I think they did. And okay, as before, as we move the virtual participants here in the room, it is same. Dr. Zafran, Jeff, and me are the only ones left.
So it is 10:52 a.m. on June 13th, 2025. We are coming out of executive session. And again, as I said earlier, while in executive session, the board did not take any action, make any decision, or vote with regard to any matter that was considered or discussed, and a certified agenda of the executive session will be made. So with that, is there any further discussion on this proposal for decision? Dr. Quinones.
I'd like to make a motion. With
Yes, sir.
regards to the matter of the complaint against Brandon Nieto before the Texas Medical Board, based on findings of fact and conclusions of law, I would move that we accept the recommendations from staff with regards to actions against Dr. Toe.
All right, a motion's been made by Dr.
I'll second
Quinones.
Dr. Quinones' motion.
It's been
Kokonos?
seconded by Mr. Kokonos. Is there any further discussion?
And just to confirm that the motion is to accept the findings of fact and conclusions of law and board staff's recommendation, correct?
That is correct.
Okay.
Okay. Any further discussion? All those in favor, please say aye.
Aye.
All those opposed?
No.
All right, so let the record reflect that all present voted aye, with the exception of Dr. Jones, with a no vote. All right, motion passes. Thank you very much. With that, we will move on to the next item on the agenda, which is our executive director report. Mr. Carlton.
All right. Well, before I get into mine, I was going to yield some of my time to Ms. Swanholt.
Thank you. I just wanted to take a moment to recognize board staff, Mr. Neldner and Ms. Massey, as well as Mr. Rivas, who I believe is still here. It does take a lot of time and resources to go all the way through with a proposal for decision and a final order after a hearing. So I just wanted to acknowledge that and thank board staff for their work, and also note that I believe we have a record here with Ms. Massey, who is resolving 5 SOA proceedings with agreed orders that have already been voted on you board, as well as a final order that was just presented and voted on today. So just wanted to recognize that and thank her for her efforts.
Thank you for recognizing your team. Thank you guys for the work you do. Kind of along those lines, I also wanted to thank the staff for their work during this legislative session. Every session has kind of its own personality, and this one was no exception. So with a lot of long hours and late nights, the staff did a fantastic job in responding to legislative requests for input on bills, providing information, prepping both Dr. Zafran and myself in being prepared to speak to the legislature. And so all in all, I think it was a successful session for the board. We've already done the legislative updates, so I won't rehash all of those. For our budget, I will let Joey give you kind of the overall for how we're doing, but just wanted to quickly recap when it comes to the legislature. In this session, we had multiple exceptional items that we asked for in our legislative appropriations request. We ended up getting about $2.5 million in funding that was restored from the budget cut that we took a few fiscal years ago during the start of the pandemic. We also received about $1.3 million for additional staff and 8 FTEs to go with those funds. And we also got about $300,000 for 2 additional staff for a new ombudsman office that we're going to begin here in this upcoming fiscal year. So we're going to grow from 260 FTEs up to 270, and we should actually have the funding now to fund all of those FTEs, at least to some level. So that is a big win for us in getting about additional $4.1 million for this upcoming biennium. With that, I'll turn it over to Joey for the rest of our budget.
Thank you, Brent. Good morning, board members. So Q3 just ended at the end of May. For our revenue collections, we're just shy of $31 million. So that puts us at about 71.4% of the targeted 75%. So overall, we're doing well. Our projections show that we should collect just about as much as we collected in the prior fiscal year, if not a little bit more. Historically, our revenue collections have been anywhere from 3 to 5% increase fiscal year to fiscal year. So we'll see how that shakes out for the rest of this year. Traditionally, August is one of our highest revenue collecting months, so that should put us back over to be significantly more revenue collections than we did in the prior fiscal year. Regarding our expenditures, as you can see, we are absolutely going to spend every penny that we have, if not a little bit more. So I will work with the leadership team to make sure that we don't overspend and that we do spend everything that was appropriated to us for this fiscal year. And then I also just wanted to note that in the budget report, I've added additional data and some supplemental maps for reference, and the finance team is working on including some historical information, especially with our revenue collections by license types, just for reference. So you'll have that visibility coming soon. Pending any questions, I will hand it back to you, Brent.
Thank you, Joey. Let's see, before I go any further, are there any questions so far about our legislative session or with the budget report that Joey just laid out for you? Okay, thank you, Joey. The last item that I was going to bring up is, back at the last board meeting, the board gave staff the ability to expand the use of warning letters in certain circumstances. But we've also seen kind of since then a growing trend of ISCs wanting to also use warning letters. Obviously, the ISC panels have greater authority to use those than board staff do. But it's kind of, I don't say inconsistent, but there's kind of different circumstances, it seems like, in which those do come up. And so I did want to bring it back for you guys as a discussion, as the board members, of how you would like to use those warning letters, in what cases. And there's also a lot of, we use custom letters. Do we want to potentially use warning letters instead of custom letters if you want to do additional tracking? But kind of bring it back again, put it up to you guys for a discussion on how you might want to go about using those.
Yeah, thank you, Brent. And I think we always look at how we can improve our processes and make sure that we give our licensees additional options. I know that there have always been concerns that there has not been, for example, in the past, a middle ground between a remedial plan and dismissal. And with COVID, we had come up with the ideas of the warning letters as a way to address concerns, but not make it something that is an official remedial plan. The problem that we have with that is that everything that we do in ISC hearings, whether it's a remedial plan or whether it's a dismissal, is reviewed by the DPRC. As we have it right now, warning letters are not part of the process that is reviewed by the DPRC. So one of the suggestions that I would make, just to make sure that we have, from a matter of completeness sake, to make sure that everything that we do is reviewable, is to make sure that warning letters are also part of what is reviewed by the DPRC, because the DPRC is not long enough as it is already. I think it's just something that we want to make sure that that in the spirit of everything, including dismissals, being reviewed, that there really shouldn't be a component that is not reviewed. So that would be my recommendation.
Yeah, and also along the lines of this overall discussion, based on the decision and the direction to staff back in March, it's been about 3 months since then. It takes a while for, kind of the ship to turn, so to speak. And so we're still a couple months away before that direction and that guidance on how we are handling those cases and staff being able to issue the warning letters really gets fully implemented. So right now you're kind of seeing the cases that are still coming through that started the process pre the March guidance from the board to staff. And so I know there's been some questions from board staff at times during ISCs like, well, why is this case still coming forward? Couldn't have been handled a different way. And again, we're looking at those were done again before the change that happened in March. So again, I think that's where we're seeing maybe the warning letters starting to be used more, but just want to make sure that they're that the board is using them kind of in the same way and they're all reviewable in the same way. And so I don't know if Chris, if there was anything you wanted to add as part of this discussion for the board's consideration.
Yeah, so the warning letters that we've been doing and pre-investigations are in a very tight window of what you've authorized us to do. And we give you the list and it's things, and then you see them come up when they're appealed and stuff. But it's like, didn't release the medical records on time, didn't update their address, didn't get proper notice. And so I just wanted to clarify those have gone to, we give you a report at DPRC, we give you the warning letters that were issued and what the topic was. Because I think Dr. Zafran just said DPRC already has a lot on its plate. So those are coming to you on a report, and then the ones that are getting done out of QA are also kind of limited to that box. So I was just want to clarify, when you say, Dr. Zafran, you want them to go to DPRC for approval, are we talking about the warning letters that you would see coming out of other contexts, like if an ISC panel offered one or DPRC offered, well, I guess DPRC offered one, you will have just reviewed it. So I guess the issue is if it's a case that's already in that narrow bounds, we're already sticking to that for pre-investigations, and you're getting a report rather than the actual letter. The one that you were just talking about where you want to see it, are you wanting to see all of them, or are you just wanting to see the ones that are kind of a tweak on the process?
Yeah,
Well,
so I think, sorry, go
I'm
ahead,
sorry,
Scott.
go ahead. Well,
No, go
and I
ahead,
was
Scott.
going to jump in here, Dr. Zafran. I think the way I understood what Dr. Zafran was saying, Chris, is the pre-investigation warning letter is the same. And what we saw yesterday was a use of the warning letter at DPRC where they're reviewed. My thought was, and we've heard this, and part of this is coming from my folks as hearings counsel that are hearing from your board members, Dr. Zafran. After at ISCs, there's dismissals where they want to issue a warning letter. I don't think it would be any different than a dismissal now out of ISC that's reviewed. And in fact, that would be exactly, I think what you're saying is, if it were an ISC dismissal with a warning letter, those would come to DPRC to be reviewed like any other ISC dismissal. So I don't think it's a change from that standpoint. But again, we saw a trend of yesterday in DPRC, and in some respects, I would put forward that a warning letter is better because you it's a little stronger saying, hey, doctor, we looked at this closely. We're kind of giving you a break, but we've got our eyes on you, which is even better than a custom letter because it's got a little more stronger language in there, and it gives the doctor the opportunity to be aware of it, but it also creates very, very identifiable accountability you have as a board. So if there's an inquiry, you can point right to those things. So I think it's good, but I do agree that my thought was if it's used after an ISC, those would go to DPRC. And of course, we're doing a few things or looking at some of the DPRC processes anyway.
Correct. And I think, if there's a warning letter that's associated with a dismissal, I mean, that kind of at least gives the board members an indication that even though it's a dismissal, it's a dismissal with some concerns, as opposed to an outright dismissal because we don't feel that there's any issues that are there, which I think are two very different things. And I think separating those two out as we review them in DPRC, I think would be very helpful, because now you're looking at something that potentially could have risen to the point of something more than that. It's not an outright dismissal. It's a dismissal with concerns, something that will be documented. But from a DPRC reviewing it standpoint, just to make sure that there's a level of consistency, which is the other thing that I wanted to kind of highlight, is that in the ISC panels, of course, we are only two of us. Some of us may be board members, but it may also be DRC members. And I want to make sure that as we put these out there, that the DPRC is a control mechanism to make sure that there's a certain level of consistency out there, that it's appropriate, that if something rises above or below the sanction guidelines, that it's something for us to be able to see and have more than 2 eyes on it. Now, at that point, you have 10 eyes on it. And it gives it just a little bit more level of oversight, I guess is the appropriate word. So I guess my recommendation would be to separate out those dismissals to dismissals that are pure dismissals and dismissals that are dismissals with warnings.
Okay. All right. And Amy, did you have some thoughts?
Sure. It sounds like we're having a discussion about what we would like to do, and I just want to highlight that how we do that is also going to take a bit of time. So if you do vote to do the thing today and you give direction to staff, as Mr. Carlton mentioned, there is some time that is necessary to make those process changes and to make sure that we are training staff on those process changes so that you see that. If you want to do this, it may not be something that you will see for August board. It may be something that you will see for the next board, which would be October. So I just want to highlight that the what you would like to do versus the how. The how does take some time before we can make that happen.
I think that's fair, Amy. I mean, it's a large change of process, and I think there's a couple of things like we had talked about the other day as to how to streamline the DPRC process. Especially when we have a large number of appellants. The question came up: do we need to have all 10 board members review all 10 appellants, or could we split that up into 2 groups and have those 2 groups review 5 each or 4 each, or however that may be, and that would still allow all 10 board members on the DPRC to come back and discuss all of the appellants that are there and that either came in person or came virtually, and still be able to have that conversation, but at least not have it in a way where the appellants are still here all day long waiting for their chance and opportunity to come and sit and talk with us.
Yes, sir, absolutely.
Okay. So is there any specific
So
direction?
I guess I'm giving direction unless somebody objects. I don't know if this is usually when we give direction, it's direction unless somebody would like to modify or clarify the direction I'm giving. But that's kind of the direction I'm asking for right now, is asking staff to delineate to the DPRC for oversight dismissals that are isolated dismissals or dismissals that are pure dismissals, as opposed to dismissals that are with warnings, so that we can see them separately and we can have a certain level of oversight over them.
And for the board members themselves, is there a recommendation that there be a use of warning letters instead of custom letters when there are concerns to be addressed? So for tracking purposes, as Mr. Freshour was talking about, again, trying to standardize, there's not too many different, a dismissal and a custom letter and a warning letter and a.
Yeah, I think for a while we were kind of using the terms warning letters and custom letters interchangeably, and I think there's a value if we're going to be tracking what we're doing, especially when we're going back to the concerns of not rising necessarily to the level of a remedial plan, but wanting to make sure that there is a concern that is being addressed short of that maybe that is a warning letter that is something that we would want to highlight. Now, I do think that we do want to make sure that there's opportunities for custom letters where, and I think the example that we've given is you haven't done anything wrong, but maybe having that conversation with the family member is something that you might want to do because that may have alleviated some of the concerns that the family had. I think that's an appropriate custom letter. That is not necessarily a warning letter where you're not identifying something wrong that they've done that doesn't rise to the level of a remedial plan, but you're asking them to be mindful of something that may be valuable and helpful, but is not necessarily to the level of a warning letter.
So more like giving them a suggestion on a best practice kind of thing. That wasn't a. So all right. So that's something we can definitely look at. I know GC can help out with all of this as well. And I think this is good overall. I know it does create some churn for staff and how to do all this. I think overall, once we kind of get it all figured out and ironed out, which will take time, but once we do, I think it will really help where the board has over the last several years has been trying to focus more on the more severe violations and allowing kind of quicker resolution for what it may be some more of the administrative type violations. So in the end, I think it's going to end up reducing staff time on some of these more minor issues. But we'll continue to work through it, and we'll see how the process goes and refine going forward.
Submission number from the phone.
I think
Mr.
Mr. Kokonos, we got your mic on. There we go. Dr. Quinones?
Yeah. Sharif, would it be appropriate at this time to also give directions to create a criteria for splitting DPRC into two bodies when we have more than, say, 6 appearing appellants?
So as the DPRC chair, and I know that you are part of the agenda making process, I think at that time when you're able to see how many appellants are planned on being there and so forth, that's probably a decision that can be made at that time and direction given by you at that time.
Okay, good.
Yeah, I would certainly recommend let us work with you as staff. Chris and I and Mr. Carlton have already been throwing on some ideas, but let's if we're going to do this, I think this is one of the things that Mr. Palazzo and myself have really been working on and bringing to Mr. Carlton is to bring a more cohesive process instead of piecemealing this. So we really want to have some input to set it up so it works seamlessly, and it's not, well, we're going to do it this way this time and then it might be different next time. I think that's also one of the things that we have already started bouncing around in view of the length of the DPRCs, particularly the last 2 or 3 times, Dr. Quinones.
Okay, good. I think it would be appropriate, and I certainly take that recommendation and suggestion. And we can always, but let's work on this, and hopefully by the time we do our pre-meeting agenda meeting 2 or 3 weeks before board, before our DPRC. Usually it's 2 weeks, isn't it? 2 or 3 weeks. We can make that decision at that point.
Yes.
So just before we go to the next thing, and we were kind of looking at an opportunity of where to have this discussion. So we talked about the warning letters, and we talked about the remedial plans, and we talked about the warning letters as being used as something wrong was done, but maybe not to the comfort level of rising to a formal remedial plan. One of the things that I really want to highlight is that we've got to have, I would hope that we have a certain level of consistency. And I want to make sure that by giving these additional things as an option, that we're giving folks that little bit of extra comfort that you've got something between an outright dismissal where you have concerns, but do I really want to do a remedial plan for something like that right now? But you want to make sure that, it is still a violation of the Medical Practice Act. You still want to act on it. And at least you have a mechanism of being able to do it in a way where it doesn't rise to the level of remedial plan, but it's still trackable. I'm hoping that with that we do have a certain level of consistency. These ISC panels are critical and they're important, and it is a very important role that we play, that we participate in. It's not a game, obviously. It's something that we participate in, and it's very important. And staff, board staff, this is something that I'd like to ask you guys to do also, is that we here have an ability to have a discussion as a board, but there's another component to ISCs that are the DRC members that may not necessarily be part of this conversation, part of this discussion. And I want that level of consistency to continue across that spectrum to them also, as to, having that level of consistency where if you're violating the Medical Practice Act and you're going to do an outright dismissal, I think we just got to be very careful of being mindful of those mitigating circumstances that justify an outright dismissal. Now you have an opportunity for a middle ground where you have a dismissal with a warning letter. And again, we're going to talk about this being reviewable by the DPRC so that we can at least put a set of eyes on it. But I don't want there to be an issue where, depending on who is on an ISC panel, somebody may get something in one extreme versus something on the other extreme. Our charge is to make sure that we are looking at each case individually and making sure that we are being fair to our respondents on an individual basis, but also fair to those who are filing complaints and making sure that we're addressing their concerns. Remember that our charge is to protect the public, not to protect our licensees. Our charge is to protect the public while being fair to our licensees. So be mindful of that. And again, I'm asking board staff to let me know and to let board know if there is a concern of some inconsistency out there, so we can have that conversation with the board and make sure that, again, we all have that ability as an ISC to operate independently with the oversight of the DPRC, and again, ultimately with the oversight of the whole board over that. So again, I'm hoping that these additional options help kind of provide those options that are out there and hopefully be able to provide a certain level of consistency across the board. So again, I think that was my opportunity to kind of have that conversation about it. If there's any questions or concerns or anything that anybody would like to say additionally, this is your chance to do so. But I think board staff has a little bit of direction and some discretion with time, given that these are some big changes, and we'll kind of move forward with that.
Yeah, and staff will definitely do their best to kind of level set every time you have an ISC and it comes to this is a potential option that the panel wants to use. Just again, just a reminder of kind of the framework of which the board is wanting to operate and utilize that tool. Dr. Stafford, I know you've mentioned before when it comes to warning letters, wanting to see potentially that whatever the underlying concern was, maybe was remediated first. I don't know if you have any comments on that as far as the panelists using warning letters. Do you want there to be any type of limitation that it's only being used if it's been remediated, and they can document that in at the ISC, and if not, then it goes to the remedial plan? Or
well, I'm trying to be careful not to be too prescriptive, but I do think that if we're going to use a warning letter in a dismissal where there are concerns that there may need to be some remediation, I know that we've seen warning letters in cases where the respondent has said that they've remediated outside of a board directive, remedial plan versus agreed order. And I know that those concerns have been felt to have been already addressed. So that could be a mitigating circumstance that could be identified. Here's a warning, but we're issuing the warning in lieu of because the respondent has done X, Y, and Z. I see Brent's point where there may be some desire for remediation that has not been done. And I think that's where the level of oversight needs to be. I think we should approach that with extreme caution. Remember that a violation of the Medical Practice Act is a violation of the Medical Practice Act. And if you're going to dismiss it outright without any kind of mitigating circumstances, that is the opportunity for oversight with the DPRC, where we do have an opportunity to kind of look at it again. But I would just ask everybody to approach it with extreme caution. This is not where our feelings and our gut is. I mean, it obviously, we know as physicians and as public members that we want to take circumstances individually. But I just want us to be careful about dismissing things when violations of the Medical Practice Act are evident, that you've got to really have a good reason to showcase to the DPRC as to why that was done, beyond just a gut feeling. Is that helpful? I think, again, this is your opportunity, board members, to kind of weigh in also. I think all of us kind of get a sense of what I'm trying to get at, but I just want to make sure that we're being fair and consistent across the board. And again, remember what our charge is. And I can't emphasize this. We say our mission statement at the beginning of every single meeting. Our charge is to protect the public, very specifically. All right.
And Dr. Zaffer, you don't mind. I mean, one thing, those of us on DPRC see the appeals, but those of you on licensure don't get to see those. But one thing I would say, just from experience on staff side, is that, yeah, if you're doing an outcome, whether it's a warning letter or remedial plan or whatever, that doesn't resolve the problem, then you're going to see that complainant back at an appeal, and they're going to be grumpy and maybe have a reason to be. So when we do the warning letters and pre-investigations, we do usually require that they're, maybe not be remediated, but that it has been addressed. So, the doctor didn't release the medical records. We require that they show that they have now provided the medical records before the case is dismissed. And so If we're doing these at the ISC level, obviously, just something that I would recommend you take into account that if the complaint is I didn't get a refund, or I didn't get my records, or I didn't get whatever, that has been addressed. I know we don't want an ironclad remediated requirement, but if it hasn't been remediated and you do a warning letter, you're going to have an upset complainant who you're probably going to see again.
Well, and I think, yes, and I think to Dr. Zafran's concern on that, Mr. Palazzolo, and we've talked to Mr. Carl, but I think the Hearings Council does a really good job in identifying that and asking board members, and quite frankly, as I said, Dr. Zafran, and even you yourself have asked this, is you ask the hard questions at the ISC, and if you feel like whatever remediation has been done or corrected or that kind of thing, it's very strongly reflected. And I think more what we're getting to here is that this is where you want to go as board members, and our Hearings Council is queuing off of that. And we do a fairly extensive write-up in the ISC reports that y'all see. So I think it's good. I think what you're really doing is just asking us to be a little bit more uniform in our use. And I think that would work fine. And I think your board members are very good about many times identifying, well, yes, this is a violation of the Medical Practice Act, but you've either remediated it or, and I think the question is asked, and I've heard you ask this question, Dr. Zafran, even if it's a violation, is action really needed on this one, or is discipline needed, or do we just tell the doctor, you better fix this, and if you don't, and you come back to us, we've got the history, because the warning letter is focused to do that. It creates a very clear notice that Chris and enforcement and investigations can utilize, but you can also readily flag and identify as board members when you're in that ISC with a prior history or a prior warning. So I think we can execute exactly what you're asking, Dr. Zafran, and I think we can execute it quite uniformly, particularly from the Hearings Council standpoint, and conveying that consistency to the DRC members as you have requested.
Last topic I was going to bring up, also just kind of looking at making sure we're bringing the information that the board would like to see in certain instances. It's have to do with temporary suspension hearings, some even the ones without notice and with notice. So I just want to make sure that you guys, if you have any concerns on the types of cases that we're bringing, if any board members, if there's things you'd like to see more of, less of, specific types of information or anything, because I know there have been a few TS hearings that we've had where maybe the board members are a little confused on the purpose of the TS hearing and the underlying evidence that's being brought by staff to the best that they have available to them.
Yeah, let me just kind of add into that also. And this is actually a request directly of my board members. If you're in the middle of regardless of whether it's an ISC or a temporary suspension hearing, if there are questions or concerns about why a case was brought up, the legal reasoning behind it, regardless of whether we think something is frivolous or not, there are laws that are out there, and it's not up to us to decide whether a law is appropriate or not. That's what the legislature's for. So even though we may think it's not that big of a deal, the law is the law, and it's up to us to opine on whether the law was broken or not, or whether there were mitigating circumstances. But it's not up to us to decide whether something was frivolous, especially in front of the respondents. If there are questions that need to be asked about the legal reasoning behind bringing something, that is what executive session's for. That is why you have a hearings counsel that is essentially your lawyer that is there to counsel you on that. It is really, really inappropriate to have those conversations in front of the respondents when it comes to the legal reasoning as to why a case was brought forward. Again, we can opine on, whether the law was followed or not, but we have no ability to opine on whether we think a law is a good law or not. There's a lot of us who have strong feelings. Maybe I think that 65 miles an hour is too much or too little. It's not up to me. It's the law, and our job is to enforce it. We are regulators with the discretion that has been given to us in statute. Again, whatever discretion we have is because of the way the law is written. So let's please be very careful and be very mindful of having those debates about whether something was appropriately brought to us or not, and make sure that we are doing those for purpose of legal advice in executive session and not in open session. And Scott,
I agree with you.
Add into that, you can please add in too.
No, Dr. Zafran, I think that's perfectly fine. And those are the kind of questions that you as board members many times ask us, whether, at a board meeting like today about a PFD, or, when you walk in and I think this is an appropriate time, and, y'all are always thanking staff. I think it's time to say to your board members, we, as particularly the Hearings Council, appreciate how well your board members and your DRC members are prepared at ISC. And what does happen in that regard that you're speaking to, Dr. Zafran, is the Hearings Council, Yvette, Sarah, Wendy, Kamisha, they literally sit down, so to speak, with the ISC panel, say, hey, here's the cases today. And your panels, yourself, Dr. Zafran, will say, okay, let's kind of walk through, we have a question about this, or we have a question about that, or these are our thoughts. So we do try to address those without necessarily being in front of the respondent or other board staff, but sometimes there is a question that we as Hearings Council can't answer. For example, quite often we will hear, and you will hear, hey, did your expert see our expert report? That sometimes we can't tell from looking at the file. If we can, we will answer it. So we are very mindful of that because we want to be respectful and not look like staff is doubting, another part of the staff. But those questions, many times, if you have them, ask them pre-ISC, or if you have thoughts on cases, because that's what your Hearings Council for. And I do appreciate you recognizing that the Hearings Council are the attorneys for you as the board members. I really do appreciate that.
Yeah, thank you, Scott. And with those temporary suspensions and impairment cases, obviously they one of the questions that's come up, I think, in maybe a recent TS had to do with interim agreements and individuals that test positive while they've entered into an interim agreement. Obviously for them, it's voluntary to do an interim agreement, but once you've signed up to do it, it's board staff is, obligation is to notify you guys if somebody does violate that the interim agreement by testing positive for alcohol or any other type of intoxicating substance. So just want to make sure that you guys do want the staff to keep bringing those forward, that there's not any concern with how the interim agreements are being done and what type of evidence the staff is bringing as far as temporary suspensions without notice.
Yeah, remember that temporary suspensions have a very high bar before they're brought to you. And again, and I know everybody here takes these very, very seriously, especially when it involves taking away somebody's license temporarily. Again, just be mindful that if you have questions or concerns about the validity of why something was brought up, that is what executive session is for. But those are also questions that can be asked before the actual hearing is opened up. I've asked that the GC staff, if any of these questions and concerns rise to the level that it's something that needs to kind of go above that at least let Mr. Carlton or myself know, and we're happy to come on at a moment's notice if need be, and of course Scott as our GC in general, just to make sure that we're able to answer these questions in a quick way, so that we're not getting into issues as far as why something was brought up, why it wasn't brought up, and then end up with more concerns, more issues after that.
Great.
Yes, absolutely.
Well, again, I appreciate you guys. Our job as staff is to make sure we're bringing forward to you guys the information that you want and that you need to make the best decision possible. And so there's just a few things that had come up here recently. Wanted to make sure, brought it to your attention, and opportunity for you guys to let us know if you wanted anything to be done any differently, and how we can support you guys. So,
hey, Brent.
Yes.
I think I heard you ask this question that no one responded to, but maybe I misheard it. For respondents that are voluntarily signing an interim agreement and violate it, absolutely 100%. I want those to continue to come to us. I've done a couple of TSs in that exact situation, and I can't imagine why anyone would not want that. I thought I heard you ask that question explicitly. Is that right?
Yeah. I did ask that question, but nobody responded. So I took it as yes, continue to bring them forward.
And Jason, to your point, yes, there are concerns that other board members may have raised as to whether that was necessary. And I think it's good for the board staff to hear collectively from the board that yes, we do feel that that is important.
Yeah, critically important. And I'll also say in reviewing those, in case there's any question, it's really clear to respondents when they're signing those agreements what's at stake, and that violating those agreements can and will result in disciplinary action. I reviewed those. It's crystal clear. I want to keep seeing them. And then also, just as a compliment, Scott, you and your staff, you know this, I've called on you in a moment's notice many times in the middle of ISCs or suspensions, and you guys are always available and super helpful. So thanks for that.
Thank you very much, and I know my staff appreciates that, and it's good to hear that they get asked some hard questions by you as panelists, and they appreciate that, but they always do their best for you.
I never ask any hard questions, Scott.
Well, you're always the exception to the rule, Dr. Zafran.
Great. Well, I appreciate everybody listening and helping walk through this. And so with that, that'll complete my report.
All right, very good. So everything else should be fairly quick after this. There is no medical director report, although I know that we've been interviewing and hopefully maybe be able to make an announcement at the next board meeting. Public information update, Tori, Sloan?
Yep, I'm here. Good morning, everyone. It's still morning. Yeah, it's still morning, just barely, but we're there. For my report today, I just want to expand a bit more on some of the legislative news you've already heard about. For everyone's reference, at the beginning of session, we were tracking about 560 bills. And then by the time Sine Die rolled around on June 2nd, we were down to 68 of those that had survived the legislative process. As was discussed earlier, most of those, if not really any of them, have been signed yet. They're still pending with the governor, so it remains to be seen if they're actually going to survive the entire legislative process. Those bills they'll either be signed, they'll be vetoed, or many of them will just go into effect without the governor's signature at all. Dr. Zafran and Mr. Carlton touched on several bills specifically impacting the agency, but aside from those that they mentioned, there's a few more that are worth highlighting. For example, there were a couple of bills that revised the pathways to licensure for military service members and their family, essentially just making it easier and quicker for them to apply for licensure in Texas. There were a few bills that changed requirements related to agency rulemaking and open records request. The vibe of those bills was more of a enhanced accountability in agency rulemaking and just increased transparency. AI was mentioned earlier today. And it was a hot topic this session in a whole bunch of different ways. With healthcare specifically, legislation was approved that would put more guardrails in place for how AI is used in things like utilization reviews and medical record keeping. There was also legislation that is intended to help guide state agencies that are using AI in our business operations. Let's see, the final big legislative topic that I want to touch on is continuing medical education. Mr. Carlton already brought up the CE related to the Life of the Mother Act, but there was another one that was passed as a result of SB 25 as kind of the Make Texas Healthy Again. That was what they were kind of calling it all session long. And it would require physicians to do CE in nutrition and metabolic health. So not CME, but CME related. There was legislation passed this session that would require all healthcare licensing agencies to use a continuing education tracking system. Fortunately, the TMB is already ahead of the curve on this one, given our existing partnership with CE Broker. Many of you know that the progress that we have made on the rollout of CE Broker has kind of been a staple of these public information updates for the past year now. And I'm excited to finally report that we officially have all TMB licensees on the platform at this point, or at least they have access to the platform. So they can all now establish CE Broker accounts as of June 2nd, I think, is when PAs and one other license type came on to help them track their CE. I know we've kind of hit you guys with a flurry of legislative information today. Many of the items that myself and Dr. Zafran and Mr. Carlton mentioned are going to be part of a legislative update that'll be featured in the next TMB bulletin. So feel free to check that out when it comes out. And I'll wrap up today by letting you all know that we are still on track to go live with the new and improved public website later this year. We'll be right on the precipice of that launch by the time the August board meeting rolls around. So that's exciting. And on that happy note, I will conclude my report today, but I'm happy to take any questions you guys have.
Thanks, Tori, and great work, helping prepare myself and Brent over the last 6 months, a lot of times on very short notice. So it's been a very busy session. So thank you for all your help on that.
Yes.
Any questions? All right. So agenda item number 19, PA liaison. There's none today. 20, consideration and possible action regarding pending litigation. Mr. Frischauer, Scott?
Yes. Thank you, Dr. Zafran. I'll make it quick to board members. We've got the usual cases going up through your substantial evidence review on some of your orders. The doctors don't like them, but really they don't have a whole lot of grounds to assert, and we will prevail in those, and we have continued to prevail in all of those. We do have one kind of interesting case going up on a revocation of a license. It's a Florida doctor at a Texas license, and I think it might have been heard yesterday, but what happened was the 1998, of course, said if a physician is convicted of a felony, the board shall either revoke their license or, if it's grounds that they would have been revoked in Texas. And in this particular case, the physician was convicted in Florida and had to register as a sex offender. And what we did was we just simply sent a letter and said, under this statute, we're hereby, revoking your license. The doctor has taken exception and said, no, you can't do it. You have to give me a hearing. And that is the issue that's being argued. It's a pure legal issue. Does the mandatory language of one statute prevail over some of the permissive language? And do they have an adequate remedy to undo a revocation once we enact it? And that's kind of where the argument falls right now, and that's being heard in court. I will give you an update as it comes through. Those things you don't see because we send a letter and just tell them your license is gone and you've got 30 days to file the appeal at state district court. So it's a little bit different proceeding. And even if, again, we'll just see what the outcome is, and I'll tell you about that if and when we get the decision. But just know it's out there. It won't have a huge impact one way or the other, depending on the situation, but it's just a topic of interest.
Great. Thank you, Scott.
Yep.
21, report on temporary suspension hearings. Those are just reports. And if anybody wants to extract any of these or make any comments, let me know. 22, report on suspensions by operation of law. 23, report on motions for rehearing requests. 24, report on cease and desist orders approved by the executive director, which may be an issue later on. 25, report on automatic orders. 26, report of cancellations regarding investigations. 27 and 28, I don't think there's any items in there. And as far as the rules are concerned, there are no proposed rules that are up for consideration, which takes us down to item number 36, which is the open forum for public comment.
Yes. So almost to the end here. So this is the point in time when members of the public, there's nobody here in the room, I think, that wants to make a comment. But if anyone online is wanting to make a comment to the board, you'll be limited to 3 minutes. So please just raise your hand. We do have one hand up. Kristen McGarity. There we go. You may unmute yourself and go ahead and just state your name, and your time will begin. Alicia, is she able to unmute herself?
Yeah, sorry. I think IT and I were battling between toggling, but you should have it now.
We're still showing you as muted. Not hearing anything yet.
There we go. Okay, now are we on?
Yes.
Thank you so much. So I'm here because I was the patient representative on your opioid prescribing work group in 2021 as you were developing the new pain clinic rules back then. And I do advocacy for a vulnerable group, the patients with pain who benefit from long-term opioid therapy. I'm here today because in the last few months, we've been seeing some escalating issues, specifically with pharmacy systems. And we've already been dealing with the DEA quotas, with the distributor quotas, with supply chain disruptions. And then starting around December, the DOJ lawsuits against CVS and Walgreens hit the news. And since then, it has been difficult to find pharmacies willing to accept this group of patients. What we're seeing a lot of is computer systems red flagging situations that really shouldn't be red flags. My sense is that pharmacists may be feeling sort of backed into a corner by the systems that they worked in, and feeling forced to turn away someone who has a stable long-term prescription, even when we have all this evidence that destabilizing patients is harmful. But if you as the patient go find a different pharmacy, now that's red flagged for pharmacy shopping and the PDMP. We're seeing still dosages over 50 or 90 MME or automatic red flags, despite the warning in the new 2022 CDC guidelines saying not to do that. Pharmacies are red flagging long travel distance, even though there are parts of Texas, rural and cities, where there really is no pain specialist who will accept somebody who's on daily opioid therapy. And even just a delayed prescription is really a safety concern because you see people who lose the ability to function in withdrawal and other pharmacies less willing to work with them than they have been in the past. So what I'm wondering might help is some sort of strong guiding statement from leadership in the medical community and the pharmacy community, prioritizing patient safety within these systemic pendulum shifts. And as always, I just want to make myself available. I'm here to help in any way I can. And I thank you for your time.
Yeah, thank you for coming and testifying and making some very important points. And they're very valid points. And I know that there's been a lot of frustration out there where, lawfully prescribed orders may not necessarily be carried out on the pharmacy side. And, as everyone knows, the pharmacists have a certain amount of discretion not to dispense. And I know that creates a lot of frustration also. We have already been talking about meeting up with the pharmacy board around some other issues around investigations that may involve compounding of ketamine, which is a different topic altogether. But there may be some value in having another not full-blown stakeholder meeting, but having a conversation. We talked about the gold carding rules that we came up with about a year and a half ago, where physicians who were part of this process would be held harmless from an audit, assuming that they didn't have any complaints against them for 5 years. We never really kind of maybe brought in the pharmacy board into that, but there may be some value, at least those who are part of that gold card process, where the pharmacy board may be able to hold their pharmacists also to a certain extent held harmless. This is a patient population that is out there that really needs a lot of help. And I know that there's this, what you brought up is exactly right, where if somebody refuses to dispense and they're forced to get a prescription somewhere else, now they're red flagged because they have multiple prescriptions in multiple places, or if they have to travel far in order to be able to find a place that gives a prescription, then that becomes a red flag also. So I think there's a couple of ideas there that we may be able to highlight in conjunction with the pharmacy board. Obviously, you as a patient advocate would be a very important part of that voice. So, let's all stay in touch and see where we can take this to the next step if we need to. So thank you again for your testimony.
Yeah, sure. So how do I stay in touch? What's the appropriate mechanism for that?
Yeah. Let's see.
Yeah.
Go ahead, Scott.
Yeah. Yes. And then Ms. McGarity. Oh, sorry. What you need to do is just, if you want to go ahead and send in your email address, I think we may have had it from those old meetings, but to be sure it's updated, you can send it into, I think go ahead and just send it in to me would be easiest, because my office and staff will do the coordination of meetings and such as that when we do rules. So I can either give you that now, or you've probably, I think you may have it. It's Scott Freshour.
I think I do. Yeah. Thank you.
Okay. If you don't, go ahead and just reach out. You know how to get a hold of us at the board, and we'll get you connected.
Thank you so much. I really appreciate it.
Oh, yes, ma'am. Of course. No problem.
Thank you. So we have another hand up. I can't see the entire name. Burkett. Oh, you're unmuted for a second.
Hello?
Yes, now we can hear you.
Can you hear me?
Yes.
Okay, okay. My name is David Scott Burkett. I'm a cardiologist, electrophysiologist here in San Antonio. I'm not trying to, I'm just nervous here. Okay, so I was recommended, somebody recommended, who used to work for the Texas State Board, recommended I get on here. And so I followed their advice. I returned from Louisiana. I was practicing for 20 years, and I signed a decree to come back here to the state of Texas. In 2022, I've been practicing here since July, and the decree, I signed it with my Louisiana lawyer, and never has anything pointed out. And he said, okay, I looked at the orders, I did it. And there are discrepancies in the decree that are keeping me out of the hospitals, keeping me out of insurances. I'm only able to see Medicare and TRICARE, and it's limiting me being a doctor, even though I can. So I hired a lawyer who used to work for the Texas State Board, and he looked at it and he said this was a strange decree. And he went to the lawyers with the Texas Board, he went to the compliance, and they said, oh, no. And basically I couldn't ever get in front of the board. So I was requesting to come somehow meet with the board, or somehow, and when I say the discrepancies, he even said that there are discrepancies. And I saw an email that the lawyer from the Texas Board sent him, said, oh yeah, I do see the typos, but he signed it. And so, basically, I can't go any further. So when I came back here, I read it, and I said no problem. So the bottom line is that I couldn't have a DEA. I had to give up my DEA if I came back here. I could not get another DEA until the Texas Board said I could, and I had to go petition from them, and that I was fine with, no problem. But they're saying, oh no, you can never have a DEA again. And so that's why I can't get hospitals. I can't get my insurances. And so my partner here says he's going to let me go. I follow with the Texas PHP. I'm in good standing. So, and the lawyer told me that he can't get any further, so I have to sue the state board. I don't want to sue the state board. I don't want to do anything like that. I'm just trying to survive. And then also when I signed it, I didn't pay attention at the very beginning. It said I was guilty of Medicaid fraud, drug diversion, and willfully giving up surrendering my DEA license. I'm never convicted of that. I'm never convicted of Medicaid fraud. I have a letter actually from last month that I had my Louisiana Medicaid. It was just taken away last month only because I don't practice there. So if I committed Medicaid fraud, they would have taken it away 5 years ago. I mean, so there's these discrepancies. I've never been convicted of any drug diversion or anything like that. And so, and I didn't see that, but my lawyer didn't point that out. I had a Louisiana lawyer at the time, so I signed it. So, and then I have a lifetime restriction, which I don't mind. I will go and
Dr. Burkett. So
yes.
So so the time's up. What I would suggest to Mr. Freshour. It's okay. It's okay. It's all right. Don't. Mr. Freshour, I know this is but Mr. Freshour may be able to have our staff get back with you offline and see if there can be some questions that would be answered. Obviously, in an open forum, that's not the appropriate place for us to answer any questions for you. But I'll make sure that our staff somehow gets back with you and helps point you in the right direction. Okay.
And thank you so much, sir. I'm so sorry. I just did what was recommended by somebody.
It's okay. It's okay. We'll get you connected with someone. All right.
Thank you, sir. Thank you.
Thank you. All right. Is there anyone else? Okay, Ms. McGarity.
Sorry, we do have one other person coming. She's on her way now. I just got her on the phone, and I think she's about to raise her hand in Teams.
Okay, we'll give her a second.
She's on, but she doesn't have her hand raised on. Yeah, there she goes.
All right. Andrea?
You're muted.
Oh, you're muted, ma'am.
Still can't hear you. You're
still, yeah, you're still muted.
Yeah, I mean, it didn't say it's going to fix it, but now they're going to look into it.
Let's see. Yeah, we still can't hear you. We can see you.
All right, how's that?
That's good.
Oh, good. Thank you. Thank you. I don't do Teams very often, so I apologize. Thank you so much for having me. I'm Andrea Anderson. I'm an advisor with the National Pain Advocacy Center, which is an organization that is not industry funded, but it looks after the rights of people with pain. I'm calling in today to ask you guys to help patients with chronic pain access pharmacy and medical services in the state. I know we all know what we've been through over the last decade with opioid litigation, settlements, and pharmacy agreements. However, we're seeing a really large leap in the number of patients that are not able to access pharmacy services. One of the big issues that we're facing is that patients are being, I'm going to use quotes, red flagged for behaviors that in the past were designated as worrisome or troublesome, but have actually become reasonable actions now given the nature of controlled substance prescriptions. For example, things like needing to use more than one pharmacy are now required because many pharmacies don't stock enough quantity or enough medications to fill any one patient's particular prescriptions. So for many patients, it's necessary to use two pharmacies. Now, Bamboo Healthcare or the NARCS Care score will flag that as a red flag and give somebody a higher risk score, but it's not actually a sign of misuse or problematic use. Other things that are giving patients red flags are things like long distances. It used to be where a patient could see a pain doctor within 15 or 30 minutes, but now we have patients traveling across the state or even from other states to access pain care. These things are being described as red flags, but are actually more normal. There are other things like this that pharmacies are doing, like choosing not to fill prescriptions at all, choosing only to do partial fills because they feel like a prescription is too many tablets, or requiring physicians to change medications if the pharmacy doesn't feel that it's the right prescription. I'm not asking you to fix the pharmacy board, but I was wondering if there was any chance that the Texas Medical Board could work with pharmacists and maybe provide some education to physicians and pharmacists that these types of things that used to be red flags may not be red flags and maybe could be examined more closely rather than, dismissing patients or reducing their medications because we think that they're being engaging in red flag behavior when in fact it may be normal for them. And then lastly, some of the physicians with whom we work have asked if there's any way that the Texas board could get more transparency for physicians from pharmacies about what's in stock or when things are coming. Patients are being told often that we don't carry a prescription, and we're having a hard time finding out if that's true or if it's just they don't prefer to fill a particular prescription.
Yeah, thank you again for your testimony. And again, this is obviously a theme that has been going on for a while. Just before I make a comment, have you reached out to the pharmacy board directly?
Actually, no, because I was just invited to this hearing about a week ago, but now that I'm aware and have met with many physicians in the state, I will be happy to do so.
Okay, I think there's some value in doing that. We, as an agency, can also communicate with other agencies like the pharmacy board and talk about how we can work together and do certain things. But I think there is just as much importance in you as patient advocates reaching out to the pharmacy board also and highlighting that these are issues. If we go out there and just talk to them, say, well, we haven't heard anything about this being a problem. Sure. So I think you guys highlighting that this is an area of concern, so that way, as we go and have that conversation with them, it's already been kind of raised to that level, and hopefully we can work together to figure out a way how we can solve some of these problems.
Okay, perfect. Thank you. I'll do that, and I will circle back and maybe copy you on an email or get back in touch with you somehow if there's a way to work together on this. I'll follow your advice. Thank you.
Thank you.
Great, thank you. Let's see. Is there anyone else that would like to make a comment to the board during this public comment section? All right, not seeing any. I think that will complete this agenda item.
All right, so I'm going to proceed on to the consent agenda. I'm presuming that we have everything ready for the consent agenda.
I can see yeah, there is nothing for agenda item 37. Did you say that? Maybe I missed.
No, I was going to do this and then come back to that. But
well, spoiler, there's nothing for 37 either. All right.
There's nothing for agenda item 37. For those of you who are new, the consent agenda, we have to make sure that all the things that we approved from the day before and so forth are in the system. So before we actually consent to it, we just have to make sure that it's there. So that's what I'm waiting on.
Yep.
Okay. I believe licensure stuff is all there. Yvette, Sarah is. Are the DPRC minutes there along with the action items?
Yes, I'm verifying that they were processed this morning.
Okay, great. We have Miss Underborn checking on the licensure ones. I do know that the prior board meeting minutes are definitely in there already, Dr. Zafran. So just we'll get our confirmation here in just a moment and finish that item up.
All the licensure agenda items are in there, Scott.
Okay, thank you.
Yes, we're good to go with TPRC.
Okay.
Thank you.
Okay, great. Thank you. So Consent agenda to be considered anytime full board is in session. So we got number 1, consideration and approval of the March 21st, 2025 medical board meeting minutes and action items. And number 2, committee reports and the consideration and approval of minutes and action items of committees meeting during the board meeting. Is there a motion?
Dr. Quinones, motion to accept both consent agenda items. 1, minutes from March 21, 25, and committee reports and consideration and all minutes of both committee meetings from yesterday.
Second, Dr. Naidu.
So motion's been made by Dr. Quinones, seconded by Dr. Naidu. Is there any further discussion?
I have a discussion item, which is that I was in attendance to the licensure committee meeting yesterday, and it stated I was absent. So I just wanted to make sure that
we will do that amendment because yes, we did note that in the minutes when you came in, but I don't think we announced it, Ms. Harrod. So we'll be sure to get that in there. So we would adopt them with the amendment indicating Ms. Harrod did in fact attend. Is that acceptable, Dr. Quinones?
Absolutely.
Mr. Freshour?
Yeah.
There is a note on the meeting minutes that noted that Ms. Harrod entered the meeting at 9:45 a.m.
Okay, we've got you, Ms. Harrod. We know you were there.
Okay. All right.
Okay. Yes, and I actually entered it was about 9:20, but I think that my presence was made known at 9:45.
Yeah, it was, and it might have been delayed. So, but yeah, we definitely know you were there. You did a lot of work yesterday.
All right. Thank you. Any further discussion? All right. All those in favor, please say aye.
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 All those opposed? All right. Motion passes. Now, is there a motion to adjourn?
Motion make to adjourn.
I'll second it, Kokonos.
All right. Any discussion? All those in favor, please say aye.
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 All those opposed? All right. We are adjourned at 12:07 p.m. on June 13th, 2025. Thank you, everyone, and have a happy summer.
Thank you. See you in August.